I might ask Marilyn Scott. Marilyn, would you be up to starting us with a blessing this session? That's my auntie. So we're really lucky that Marilyn Scott is here. And she's going to start this session off with a blessing. And I just want to preface this with, I think that one of the important things that we're doing at the board, again, my name is Donica Brown, and I'm a citizen of the Choctaw Nation of Oklahoma. And I am the Behavioral Health Programs Director at the Northwest Portland Area Indian Health Board. And I was a drug and alcohol counselor, mental health counselor for 25 years, working with tribal youth and adjudicated youth. And then I went to receive my PhD, and I did my work in my doctoral program looking at tribal-based practices as a place of healing these behavioral issues, including other health outcomes. But what we've been doing at the board lately is talking a lot about how this work that we do is actually a sacred trust. And for us, we really want to understand that we're talking about life and death now. And treatment is a life and death issue. And when we're asking people to complete, assessments and screenings and diagnosis, that these are sacred stories. They're telling us they're sacred stories, and that this is a gift for us to be able to help them. So for this, I want to open it up with that intention, to understand that treatment and prevention is a sacred trust, and that we as providers are medicine people, and that we're here to help and to listen and to guide, and that all of our tribes have oral traditions. And some oral traditions, there are certain times we tell stories, and other times we don't tell stories. There's certain people who can tell stories that other people can't tell. And so this is a sacred trust. And so I want to kind of just put that out there, that this is the space that we're going to generate today, is around that sacred trust. And so with that, when we create this space, a lot of people have a lot of ideas about what works and doesn't work. But today I want to just set that intention around the sacredness of this work. And I want to invite you all to be open to hearing different ideas and opinions and thoughts about what works and what we need to be doing that. So with that, I would like to ask Marilyn Scott to start us off with a prayer with that intention of creating a sacred space this afternoon. Thank you.
Thank you so much, Donica. Ask everyone to rise with us this afternoon. And I'm asking each and every one of you in the room to pray and provide a blessing in your own way. And provide a blessing for each and every one that is joining us this afternoon, to have an open mind for the information that will be shared with us, and that we can take this information back home and utilize it within our communities. We ask all of these blessings for all of our loved ones in the community, that each one of them will be safe, and asking that we have a blessing for all of our community members that are not well at this time, for our families that have losses at this time, provide them the strength that they need to get through this hard time. We ask a special blessing for our state leaders, our tribal leaders that have brought us all together here today. And we ask all of these things in your name. Amen. Haishka.
Thank you, Marilyn. And so the other thing is we want to open this up more as a conversation versus a panel with question and answer. We want to open it up. We know that there are amazing things happening all over Indian country, best practices that are being created right now. We're starting to understand how tribal-based practices actually are medicine, are interventions, are prevention. And so, but within the Western world, they don't understand what that means. So we also want to talk about that, and how do we open up an understanding about how our traditions are healing and how it is medicine. And there are examples that are happening all over Indian country for that, and also in the Pacific Northwest. But with that, I would like to just kind of go down the row. I don't have questions prepared for the panelists, so we're going to let them speak from their heart, and then we'll open it up for questions or discussion from the room. So we'll just go down the row. Go ahead, Amber. Yes.
Good afternoon, everyone. Can you hear me all right? Excellent. My name is Sharisa Fatinos, and I work for the Healthcare Authority. I'm the Medicaid Director and the Behavioral Health Medical Director. By training, I'm a family physician and addiction medicine physician, and I've been doing this work for about 30 years. So I hope to bring my current knowledge and my history of having worked and lost patients over the years due to addiction, and specifically opiate addiction, to you. I also want to start by thanking the Lummi Nation for their graciousness in hosting this event and allowing us this space and time. I'm gonna try something different. For those of you who've heard me talk, you're like, she says the same stuff all the time. So I'm gonna try a little bit different way in doing this. I'm gonna start with 3 words, and I'm gonna end with those same 3 words. And the 3 words I'm gonna start with are medication, connection, and community. And I'm gonna talk about why I think those words are important. First off, a couple words about medication. When we talk about medications for fentanyl, we're talking about 2, and that's buprenorphine and methadone. And people will say, but what about naltrexone? What we know from the science is because fentanyl is so strong, naltrexone is not able to provide that coverage of receptors that the fentanyl does. And it prevents people who use fentanyl when they have naltrexone in their system from overdosing. But because it's not sort of occupying those same opioid receptors, it removes their tolerance very quickly. So if someone has a naloxone or a naltrexone shot, and they are more than a couple days after it's due, they have 0 tolerance. So if they think they can go back to using anything they did before, they will overdose. And studies are showing with fentanyl that it's not as effective in keeping people alive, keeping them engaged or in treatment. So I'm not saying that there aren't excellent uses for naltrexone, there are, but with fentanyl it's different, and that's my theme here. Fentanyl is a different ballgame. I've been doing this for 30 years. When I started, it was heroin, then it was OxyContin, then it was heroin, and now it's fentanyl. Fentanyl's a game changer, and I brought a prop. I'm gonna ask maybe Danica to pass this around. Pretend when you hold this that the biggest thing in here you see is a pea. It's really a rock, but it's supposed to be a pea because I couldn't find an unfrozen pea. That is, if someone is not used to taking opioids and they took pure morphine, that is how much it would take for them to overdose. The sunflower seed is how much it would take someone using heroin who's not used to opioids in their system. There is a sesame seed in there. That is how much fentanyl it takes. So I want to pass this around and have you really appreciate, I think, through seeing this, what we're talking about. We're talking about a drug that is extraordinarily potent. It acts really quickly, and it releases the amount of dopamine and sort of euphoria and a high that is not comparable to what heroin was in the past or oxycodone was. It acts quickly, it acts powerfully, and it goes away quickly. So when people in the past could get away with using heroin 3 or 4 times a day, they're having to use fentanyl 10, 12, 14, 16 times a day. And if any of you have lived with or been around folks who have an opiate use disorder, maybe for those initial times they're using, they feel great and they like that high, but very quickly it's not about that high, it's about not going into withdrawal. That makes you want to jump off second-story buildings in King County Jail onto the cement below because you'd rather die than go through a withdrawal. And we heard Christy's story this morning about that. So I would urge us all to think about fentanyl as being different. Going back a minute to connection. Connection means, again, the love that we heard from Christy, what we heard from everybody is being there for folks. Connection needs to occur with empathy. Doesn't mean you have to take on someone's pain, but you need to be able to sit with it and be able to appreciate that what you're hearing from them is their reality. It's their truth. And when there's connection and empathy, there can be hope. And without hope, really any of these things we're trying to do, take any problem, is much, much harder to do. So empathy, connection can build hope. Community, I have to look at this because I was at a conference last week and there was a minister from Minnesota, and he said something that has stayed with me ever since. And this is his definition of community: the way people behave when they believe they belong together. The way people behave when they believe they belong together. As I said, I've been doing this for a long time, and the strongest and most present communities are those I've seen within the tribal communities. You know, we don't have white communities, but you all have a foundation, you have a tradition, you have a history. You have your people belong. And so I think that is probably more protective and resilience building than many of other things we can build. So I want to just also spend a minute or two sort of asking for all your help. I myself have not been someone who's struggled with addiction. But I choose as a professional and as someone who's spent my career and has many family members, some who I've lost to addiction, I have chosen not to use the word addict. I have chosen not to use the word clean or dirty. I have chosen to move from the word of detox to withdrawal management or transition services. For people who are using substances or have a substance use disorder, they obviously are entitled to choose whatever words they want to use for themselves and their community. But one of the biggest problems we have is that of stigma. We judge people. And if we say you're clean or you're dirty, well, that just sets that person up for failure if for some reason they, have a drug in their system that wasn't expected. So I think that part of this is really reducing the stigma and discrimination that occurs, and we heard a little bit about that this morning, the importance of that. And I think that's where that connection piece comes from. Sitting with people where they are without judgment. I can't imagine having to be driven to the point of wanting to die to do something 20 times a day that I'm loving my life. I'm not. I've hurt my family, I've hurt my friends, I've hurt myself. I don't even see myself in the mirror, as a gentleman this morning said. That, at a minimum, deserves us sitting with someone. And so I think that's where that connection piece comes in. I think probably just to close, I think there'll be more opportunities to talk, but I think with fentanyl, we have to have a paradigm shift. There are few people, and we've heard a couple examples of people who can stop using fentanyl without the assistance of anything. That worked for alcohol, it worked for oxycodone, and it worked for many people on heroin. It will be the exception that people can stop using fentanyl without some sort of medication. Medication is not assistance. It is not medication-assisted treatment in the age of fentanyl. Medication is the treatment for fentanyl use disorder. And when I say that, that's for the symptoms of the up and the down, the withdrawal, the feeling horrible, the feeling normalized. Unless and until people are stabilized on medication, at least for the initial period of time, they're not going to be able to engage in treatment. They shouldn't be asked to tell their life story or all the traumas or all the things that have happened to them or all the things that they were forced to do in order to not feel like they couldn't go on anymore. So medication is the treatment. It reduces death by 50 to 70%. I'm a physician. I can't prescribe anything that's that effective. The other thing I would say is let's rethink how we talk about harm reduction. Harm reduction is an important principle. I'm a primary care doc. I treat diabetes, I treat high blood pressure. I cure nothing. I prescribe medicines to do harm reduction. I do harm reduction so that person with hypertension doesn't have a stroke or congestive heart failure or kidney failure. But I don't cure their hypertension. Can we rethink how we think about helping people lessen their risk when they're doing things that aren't healthy for them? And I'll leave you with one other thing that struck me. Absolutely, the justice side is important, and eliminating the supply of fentanyl is important. But I think there's the demand issue. The demand issue speaks to what are we giving people for alternatives? There's historical trauma, there's the trauma of poverty, there's the trauma of having been a victim of violence, a victim of trauma. Everybody's path to recovery is different. We have to recognize all those things and make all those options available. For some, it's 12 steps. For some, it's trauma therapy. For others, it may be something completely different. We all have our own paths to walk, and we all know what is best for us. We have to allow people the opportunity to share with us what they know will work for them. But until they've had a chance to be stabilized on medication, they're not going to be able to get that clarity we heard about from Christy Stun-Lane. So I think this, for me, is an opportunity for all of us to redirect how we think about things, how we talk about things, and know that fentanyl is different and that we have to approach it in that way. I'm going to stop, turn it over to my colleague, Dr. Waterland.
Thank you. Can everybody hear me? I don't know if this one is on. Yes? Oh, hi, thank you. All I have to do is ask the question, and it's on. Oh, hold on.
I ruined my own plan.
Oh,
Medication,
here, yeah.
connection, community. See, I got it right.
That was good. And you know when you're on a panel and somebody writes really great kind of things to make sure that you touch on, and then the person that goes before you says really great things, and you start to make notes on what they said so that you can say, oh yes, as Sharisa said this. And so I found myself really listening to you and thinking, absolutely, I'm going to touch on some of the things that I was prepared to talk about, but I guess I'll introduce myself first. I always forget that part. My name's Carrie Waterland, and I am our director of our Division of Behavioral Health and Recovery at the Healthcare Authority. And part of that comes with the designation of being the Behavioral Health Authority for the state of Washington. I'm really honored to be here today. I'm honored to work with Sharisa, who's our not only Medicaid director, but behavioral health medical director. You heard from our director already today, Sue Birch. I'm really honored to be here with her today as well. And thank you so much to Lummi Nation for hosting this, for, I think, being brave and tenacious enough to mention it and not let it go and see what could happen in such a short amount of time. So thank you for hosting and for everything that you have done to bring us here today. It's a huge honor to be here today to, I think, kind of riff off of Sharisa a little bit, which is if we do things right in behavioral health, we will be working our way out of closing down treatment facilities proper, right? And we're doing a lot of talking today about medication, which is absolutely the intervention for most opioid use disorders, or opioid use disorders as a class, right? And so I know Sharisa has that on lock. And I'm just going to touch on then the connection and community piece. And since the Surgeon General's report came out, the advisory on loneliness, and this being potentially our newest epidemic, it really got me thinking about that is prevention, that is early intervention, that is the key to us moving toward closing treatment facilities down, not because we can't afford them, but because we don't need them. We haven't waited until folks have gotten sick. We haven't waited until, and this is coming from a behavioral health person, right? We haven't waited until folks have a diagnosis, because we've gotten to a place where we have prevention set up. We have communities that care. We've got places for folks to go. We're not waiting weeks and days. To early intervention, to recognizing the signs and symptoms of early use. To teaching those in our schools and in our community programs, and not putting a moral spin on that, but a medical spin on that, right? Because what it comes down to is this is just a healthcare issue. And we don't wait until it becomes a diagnosis where you need inpatient treatment for many of our physical health needs, right? We know as a people that early intervention leads to better outcomes. It leads to us being able to treat things better. And so listening to Sharisa just made me continue to think, we are talking about opioids today. We are talking about fentanyl and the fact that it is a whole different game. And as somebody said earlier today, rock bottom with fentanyl is death, and we can't wait for that. And I'm gonna challenge us today as a group full of people who are super smart and who care to share, how can we move even further? How can we move even closer? How can we move even closer to the start? What are the ideas that we need to come together to say, medication is absolutely what we need once someone has an opioid use disorder? What happens before that, and how can we lean in and challenge ourselves? I'm very interested in hearing, because I know that tribal communities, that is the backbone of the belief, of the community, of the way that folks interact. And so what can we as a state learn about community and connection and the healing power in that? So while I know we're going to talk about the treatment side of things today, I'm really hopeful that we touch on the prevention and the early intervention and the early identification so that we can start to get at this before we get diagnoses, before we need medication, and before we have to even pull out that handy little manual that all of us have to pull out in order to bill. So I am going to stop talking, because I get to this point where I start to repeat myself, and I'm just not going to do that. But I'm really excited to hear the ideas and to make commitments about what it is that we can do as a state to learn about the social determinants of health, of housing, of food, of all of the good tribal models that are currently in existence that we can learn and grow from. So with that, I will stop and say thank you so much. Chairman.
Thank you. And thank you all for joining us today, this afternoon, for being here at Lummi Nation to have this discussion. A couple of things. I just realized that I'm up here with two doctors, and might not be maybe the best fit when it comes to the expert work that needs to happen to address the drug epidemic, but I do have a point of view from tribal leadership and being a part of this community and being impacted by opioids and the drug epidemic that we see today. I also wanted to mention just how far we've come and the frustrations that we have had for years trying to get this up and running, a time where we can all come together and talk about the issues that we see in Indian country, and specifically at Lummi. I want to acknowledge Ingrid, if you can raise your hand real quick. This is Ingrid Early. She's the HHS Region 10 Director, and and when she was, we actually were here. We were on the stage over a year ago, and that was when we were talking about we need a summit. We need this to be at the forefront of issues and a priority of Indian country. And at that time, the room, there was only maybe 10 people here, and now look at the progress that we've made. We still need more. We still needs to be more people here, but it's a great start. So how far we've come, I wanted to acknowledge that. And what the doctor said about empathy, having an opinion is probably the lowest level of human knowledge. To have opinion, to be opinionated, to have an opinion about something, and really it requires no accountability, it requires no work. We can have an opinion about anything, but to take the time to actually address it. And probably the highest level of human knowledge is empathy, the ability to take yourself out of your shoes and put yourself into someone else's position, to put your egos aside and to be a part of something that is much greater than yourself, comes with empathy. And so I'm really thankful that you mentioned that, because that's why we're here today. I think we all have empathetic hearts for our people, the ones who are really struggling in this world, and how to address the drug epidemic. The struggling single mother whose family is impacted by it might not be using, but might have this heart, who's trying to take care of her whole family. She's out there right now, and what are we going to do to help her? What are we going to do to help the people that are and really not just as a government, the frontline workers who are doing the work, who are sharing their empathy and their leadership with us, but the community members who are out there just trying to get by. What are we going to do as a people, and how does the state come into play on how we're going to address it as a community, as Native people? At Lummi Nation, we narrowed it down to 3 areas of prevention, intervention, and rehabilitation. And we are doing everything we can to make that a priority. And we see, you'll see it tonight at our culture night. We'll have youth there who will be picking up a drum, who will be wearing regalia, who will be singing songs and dancing. That's prevention. The children who are growing up never forgetting who we are and where we come from. That's very, very important. And to keep them safe, to keep them protected from all of the negative aspects of the world. In addition to that, that's just one example of many, but to strengthen that is really important, to start with our children, and that's so hard to do because we care for all of our people, all of the people that are right now struggling with this world of addiction, that we want to take care of them at the same time of taking care of the people that are coming behind them. And so in addition to that, we're at Lummi Nation, at least, we're trying, and we most recently are opening up a new life center, a stabilization center, to address the drug epidemic 24/7. It's really an expansion of services of our Lummi counseling services of medication-assisted treatment. We're getting methadone up and running as well. And as a part of that, one of the issues that we saw is that there's no beds available. There's no place for our people, that you have to schedule an appointment to get them here to get into our program, to get the treatment and help that they need right at that time. And that's been a barrier, that's been a struggle. But now with this open, which it is our way of doing it right away, to not wait to get the work done. It'll be a 24/7 service. So somebody at midnight who is ready to get clean and wants help, that we have a place for them, that we have an open door. That's kind of our way, our teachings from our elders and our ancestors, the former leaders that came behind us, that we can't wait. We're not going to sit around and wait. We know the issue, we see the issue, we experience the issue, we feel it, and what are we going to do about it? And that's some of the struggle that we see dealing with the state and federal government, is that we have to wait through these bureaucracies and turns of leadership and political divide, and just this misunderstanding of what a treaty tribe is. And that brings up the next point, is we signed a treaty. We did not go to war. It was a peace treaty with the territory of Washington State, the Point Elliott Treaty of 1855, in which our elders, our ancestors, moved from our original territory onto this reservation in exchange for specific rights, rights to health care and education, our right to fish in our usual and custom areas and hunt, our right to be Lummi, our right to practice our way of life, our right to be who we are. And from then, there's been ongoing policies that have been put in place to try and get rid of us, to kill the Indian and save the man, yet we're still here, which means that a lot of the work that we do, especially with our culture, something's working, and we are resilient, and we inherit that from our ancestors. But going back to the point of the treaty, it is not our understanding of upholding treaty rights and trust responsibility, for us to have to apply for grants, for us to have to compete against other tribes to go for money, the much needed funding that we need to fund the services that we're providing, like the New Life Stabilization Center, like the secure withdrawal management, the detox facility that we have a vision of building at Lummi in the near future. Our new clinic that's being built right now, it's a tribal health clinic, 50,000 square feet, state-of-the-art services for our people. We took a loan out to do that because of the ongoing issues that we face throughout the country to try and get what we need per the treaty. And so it's a fight, and we're always going to do that. But I think one of the biggest things that we want out of this is an understanding of the true history of this place that we call home, and understanding that there was a treaty signed, that it's a shared history. It's not just Lummi history. It was the forefathers of this area as well. Their signature is on that agreement. And so what are we teaching our next generation? Are we teaching them that this is how we're going to conduct business? Or can we teach them at an early age of this is the true history of this place we call home? And our hope is that if we can do that, then they'll grow up sitting at a table next to each other, our children who will be the tribal leaders, and the children of the state who will become the state leaders, and at least have that acknowledgement and understanding of each other, so that we don't have to always do this. We're tired of meeting. And my Auntie Penny Carroll, I said this earlier, another former council member, my Auntie Penny Carroll, who is here from the Lummi Victims of Crime, tells us we're sick of meeting. We're done meeting about this. What are we going to do? What are the solutions? What are we going to do together to address this drug epidemic? We don't want another meeting where we walk away and we feel empowered and we feel good that we're showing up and we're talking about it. But we want to walk away with a real solution, something tangible, something that we can walk away feeling that knowing that we're making a difference in the lives of our people. And so with that, I hope that we can bring it to the audience here. The idea for this summit was not for us to just report out on the work that we're doing as tribes and as the state, but to talk about solutions. This is a time to talk about the gaps that we see, the issues that we're facing. Some of you are the frontline workers in addressing this drug epidemic. What can the state do better to help us address prevention, to help us prevent treatment and recovery? What are our needs? What are our funding needs? What are the laws that are impacting our ability to take care of our people, to take care of ourselves? That's what we want to hear today. And there's a couple of questions just to get you all to start thinking about what we want to hear from you all. What are some of the most important issues we need to confront regarding this fentanyl crisis as it relates to treatment, recovery, and prevention? And what are the barriers and gaps in what we have available? Just wanted to mention those questions and reassure everyone here that it's not just an hour and a half of us talking. We really want to listen. And from this discussion today, we're going to bring it back. We're going to have a facilitators meeting we'll have another session this afternoon, and then a facilitators meeting after that, and then another breakout session tomorrow morning, if I'm not mistaken, and then we'll be reporting directly. The governor of Washington will be here tomorrow, and that's our time to say, well, at this treatment and recovery session, we talked about this. These are the solutions. This is what we need the state legislature and the state agencies to address as a way to help and acknowledge us and understand us as tribes. So thank you.
So I was taking a few notes, so I want to summarize, and then we're going to kind of open it up for this discussion around the questions that Anthony shared. Empathy is a really important aspect of what everyone shared. But as the auntie, I'm going to be real, right? People who use drugs are really hard to like. And part of it is because what we need to understand is that it's a trauma response. Addiction, as we know it, is a brain disorder. It's not a disease in the way that getting a cold or, that it's a brain disorder that's tied to trauma, specifically early childhood trauma, which changes literally the way our brain functions. And specifically, the aspect of trauma, it's the disconnection. So a lot of times when we talk about people who use specifically opioids, one of the things they'll say, especially when I was doing treatment with people who used heroin, what they would say, it was a common theme, and a lot of you in here have probably heard it, it's like having a warm hug, right? It's like the most basic human need is a warm hug. And that's what opioids in particular do. Gabor Mate, Dr. Gabor Mate, he says, addiction is about the pain. So also being a brain condition, a brain disorder, is that emotional pain and physical pain are processed in the very same brain centers of the brain. So our brains don't delineate between physical pain and emotional pain. And opioids are a powerful pain reliever, right? So when we think about trauma, we think about the brain, we think about the way it works, the reality is it is hard to have empathy for people who are dependent on drugs because they're in their trauma, my mentor always says the drama of the trauma, right? Oh, they're in the drama of the trauma. We got to get out of the drama of the trauma. We have these fight, flight, freeze, and fawning responses. And people who are dependent on drugs really know how to be in the drama of the trauma. And it is challenging to be empathetic. I was a drug alcohol counselor for 30 years, and I had, what we called quote unquote frequent flyers. And it was real tiring. But that empathy is core because it's the connection. And that's why culture, what you were saying, connection is an important medicine. But what does that mean? And that's why culture is powerful, because it brings us connection back to our community, to our family, to our ancestors, to our land. So some of the work that I'm doing right now at the board is thinking about cultural connectedness, and specifically cultural connectedness in the sense of ancestral connectedness. What is our connection to our ancestors, to our relatives, to our spirits, to the other world, our ancestral domain? Connection to the land, and specifically our traditional homelands, where our creation stories are, where our ideas and understanding of who we are in the world come from, our connection to our communities, our connection to our family, and our connection to our culture, the activities that we do. Because we also know we have a lot of people out there who do a lot of the things, but they're not acting very well, right? They go to all the powwows, they're ceremonial people, they go to ceremony on the weekend, but then they're still drinking and drugging and causing harm in their community. So for us, it's really thinking about, it's not just doing the activities, it's how connected you are to your culture. So obviously our theory is, the more connected you are to those things, those aspects of culture, the more protective factors you're going to have. Dr. Karina Walters, Jane Simone, and Tessa Evans Campbell from the University of Washington have done some research and writing around cultural connectedness and culture as a buffer. Like we said, we know that Native Americans experience higher rates of health disparities, higher rates of substance misuse, mental health, all of the things, and it's related to historical and intergenerational trauma. We don't need to do more research on that. But what we're saying is that when we increase our connection to culture, it acts as a buffer to mitigate the impacts of stress and trauma on health outcomes, whether it's physical health, substance misuse, mental health, or other outcomes. So now there's a lot of research in Indian country happening looking at that, because our funders, bless their little hearts, don't understand that, and there isn't evidence to show that that is actually true. Lots of anecdotal research, knowledge showing that when we're connected to our culture and community, that we're less likely to engage in this, in substance misuse. But what does that actually mean? So we're starting to do research on it. And we are working at the Northwest Portland Area Indian Health Board with Johns Hopkins to create a cultural connectedness scale so that we can start actually gathering this data to show that when people are connected, when they're engaged in their culture, when they're engaged in their community, that there is positive outcomes. So we're working on that, but we're not there yet. But we know. How many people in here know that culture is healing? Culture is intervention. Culture is prevention. We know. But we need to actually get that data and really thinking about those mechanisms. And thinking about understanding trauma and the healing of trauma. Trauma is our innate desire to survive. That's a beautiful thing. It's actually hard to take your own life, right? Because your body is surviving. That's a beautiful thing. But the skills we learned, those trauma responses then become maladaptive, right?
Become learned.
So we need to learn more skills. And that, we were also talking about primary prevention, making sure that our children are happy. Three of us on this panel just went to Iceland to look at their youth prevention, and I was crying. Mm-hmm. We went to a high school dance, or it wasn't even a high school dance, it was a dance with high school age students. And I was crying because they were so happy and not on their phones. And when I was talking to Chairman Lewis, he said, I've never seen our kids like this. I said, in America, our kids have a heaviness. And Native American children even more they carry a heaviness because of the historical and intergenerational trauma. But their whole thing is primary prevention. Kids need to be children. They need to be children and have fun and engage in sports and do leisure activities and go to school and do these things and be children. And that's an important part of it. And then, that healthcare is, health disparities can be, health, I'm not thinking of the right word, but, we need housing, we need care, we need food, all of these things which are tied to early childhood trauma. The other thing that I want to kind of lean to what Anthony was sharing is praxis. We're done talking. We've been talking about this for years and years and years and years. We need to start doing. We actually know what we need to do. We just need to start doing it. And I can say, as an employee of the 43 federally recognized tribes in the Pacific Northwest, these communities are done listening, done talking, they're going to start doing, and the state and the feds need to just kind of jump on board. And that's my understanding and interpretation, because we're moving forward, and you all need to catch up. And so, understanding, and we also talked about harm reduction. I think there's this perception that harm reduction is one thing. It's having safe injection sites. It's providing MAT. It's doing this. Harm reduction is a continuum of care and services. 12-step and abstinence only is on that continuum. That is also harm reduction. The point of harm reduction is being client-centered and counselor-driven, identifying what the client needs to access recovery and what that means for them. Because for some people, we heard this morning, recovery doesn't look the same thing for everybody. Recovery for everyone is not going to be abstinence for everyone. For some people, it is, and that's important. So, but providing as many resources, prevention, intervention, and rehabilitation as possible, that's harm reduction. So moving away from this idea that harm reduction is this one thing, that's this like extreme thing that's over here, and understanding that harm reduction covers the gamut of all services that we can provide. And the point is to coming to where the client is and what they need, listening to them, hearing them, and engaging with them in the development of their treatment plan together and what that could look like. Did I miss anything in my long-winded summary of that?
That was good.
All right.
Could I offer just a quick response and request to the audience as we turn to you coming up here? I think, as I mentioned, I've been practicing medicine for a while, and a lot of what I've learned is from watching people and learning what works and usually what doesn't work, and at the end of the day, that the person in front of me is the best able to tell me what they need, when they need it, and how they need it. And I would just offer two sort of examples of how to think about things. I agree with Chairman Hilaire and Danica. I'm tired of talking about this. I've been talking about this. I've been prescribing drugs forever. I've been talking about this. And don't think we're going to turn things around in a year. That said, we can make mighty steps. We can make mighty steps. And I would just offer to all of you when we're thinking about what kinds of things we might do differently, I want to think about with heroin and oxycodone, it usually took people 5, 6, 7 years to go from first use to developing an opiate use disorder. With fentanyl, that's shortened down to less than a year, sometimes months. So what used to be quieter in the background until it couldn't stay quiet anymore, we're now seeing much more quickly. And we know from hearing the stories this morning, and from all of you know, it's a chronic condition. It's not something that 30 days of treatment, 60 days of treatment, 90 days of treatment makes go away forever. That those skills, that resilience, that connection, the community involvement, those are the things that have to be ongoing to help people stay in recovery. And that would it be disingenuous to suggest that if anybody ever relapses, they failed their recovery. And part of how I've started to think about this in my head is, how many of you out there know someone with diabetes? Everybody should raise their hand, right? Everybody, right? Whether, no, I'm not asking if you have it, I'm just saying most everybody knows someone who has diabetes. If you have type 1 diabetes, meaning you have to have insulin to live, that just is. I don't kick people out of my practice when they don't use the right insulin dose, because that's something that without which they die. What about people who use medications to control their diabetes? What happens, there's a right, glycosylated hemoglobin, hemoglobin A1C. That's the number that we as physicians try to get people in this range of control of their diabetes, not because they necessarily know that they feel better, it's because that's the level at which the long-term risks of kidney failure, blindness, heart disease, and stroke are better controlled. Imagine a world if someone, instead of that 5 to 7 range, when they came in at a 9 or a 10, and they didn't have a place to live, they didn't have regular food to eat, we said, oh, you gotta go to jail. You couldn't manage it, didn't have the willpower, you didn't have the strength, you couldn't manage your diabetes, or I can't take care of you. And fundamentally, we're talking about something similar. We're talking about managing something that someone is gonna have to work with and acknowledge that they have for the rest of their life. Sometimes it's gonna be easier, sometimes it's gonna be harder, but within that is the grace that I think Danica, wherever she went.
She's got the money.
Danica went. She really said it well, it is hard sometimes to sit with people who don't like themselves and have done things that they would have never imagined they would do. And they can be grumpy and obnoxious, and I've got yelled at more than once, probably rightfully so. And I know that if they were feeling better and they weren't in the throes of that cycle of withdrawal and managing the symptoms and withdrawal and managing their symptoms, They'd be that little kid whose face we saw up on the screen today. They'd be that happy, smiling young woman with a crab or lobster, I don't remember, some crustacean. And so I think that that's hard to remember when someone's in your face and they're not well themselves. But take that away and that's where they are. And I think to Danica's point, that's why the empathy is so important. So I'm done for now.
I also want to add, can you hear me? Okay. You know, this morning too, someone talked about with fentanyl, it like turns people into zombies, right? So there's something specifically happening there in the brain again, where opioids in particular, but fentanyl, I think it's even more pronounced, is it affects the empathetic system of your brain. So it disconnects your empathy. That's why people who we know and love, who are sweet children, that were the sweetest, compassionate, loving people, become these zombies where they're willing to steal and rob and do horrendous things. It's not because they're a bad person. They're impacted by the drug. And that's, I think, an important thing we need to start talking about, because it's one of the things in the stigma or stigmatizing of people who use drugs. That's part of understanding that it's not their fault. They are literally a different person. They have a different brain. They're impacted in ways that we are just starting to understand. And so when we see someone that we loved, and they're acting in such a drastic different way, it's because that drug is really changing the way their brain is functioning. So if you can understand that, it's easier to have empathy for someone who's being prickly and mean and stealing and robbing and doing all the things. I always said in my practice, the harder they were, the more love they needed. And so I used to work for probation, and I ended up working with kids who were being direct filed on as adults. So that was like, I ended up getting the hardest of the hardest. And I was hugely successful with them because the harder and meaner and tougher they were, the nicest and sweetest, and the more love and compassion I gave them. And they responded to that. And so, you know, when we're thinking about that and just even thinking about our loved ones, like, give them more love. Instead of having them search out for that warm hug in the form of a drug, give it to them. You know, be that person, be connected. So with that, we're going to open it up for conversation, and Anthony's going to share with us those questions again, and then we will open it up. And Lisa over here also has a microphone, and I'll be on this side, and she'll be on that side.
Thank you, Danica, and thank you, panelists, for the remarks and comments. Again, we want to come together and talk about solutions in ways that the state can help us as tribes to address some of these issues. And just to reiterate the questions here, what are some of the most important issues we need to confront regarding this fentanyl crisis as it relates to treatment, recovery, and prevention? What are the barriers and gaps in what we have available?
Hi, everyone. My name is Noreen Hill. My traditional name is Gajit Jalongwas. I'm from the United Nations, and I'm the CEO and founder of Mother Nation. And we have a women's recovery house. And there's just a couple of things I wanted to speak on, to share with the struggles that we've had on our path. We're 10 years now in operation, Spirit Journey House. And we take women who are homeless, who are independently in recovery, coming from treatment. A lot of folks, like they're saying, you heard all the morning today, was that they're not ready to, some people get out of treatment, they relapse right away. So the Transitional House is a 2-year program that helps them stay on track and gives them cultural healing tools. It was designed actually by the women who live there. The name of it, Spirit Journey House, was given by the women who went through the program there. And 4 out of 5 women stay sober. They get into housing, they get back with their kids. The cultural program and the love and environment that we support for them is what's key to them being accepted and finding themselves again as a Native women. So we offer different types of healing workshops there, talking circles, we have sweat lodge in the back. And a lot of the circles that we do is from the elders that came in and they came out of their retirement to be with us to do the work. And it's really important to understand, like, it's a 5-bedroom house. It's very small because the women come walking through with everything. They're survivors of trafficking. They been into drugs and alcohol. They've been into sexual violence. They were domestically, hurt by their partners. Some of them don't have family here. Some of them are part of the Relocation Act and third generation that have been on the streets. So we help women who are from different, like both on and off reserve, and we're creating a Spirit Journey House village there so we can help have a transitional house just for sexual assault survivors, one for women with children. It's very hard to find programs for women and children in recovery in a lot of areas that practice the culture every day. So we have different cultural healing programs that they agree to be part of, and we let them know that it was designed by other sisters that came before them. So for instance, we'll have a Dreamcatcher workshop that an elder will come in and do, and she'll have them put a pony bead on for every milestone in their life and what has happened to them. And part of that whole activity that they do, once they get done doing the Dreamcatcher, they share their story. And it takes them out of that stage of onset to who they are today, to start honoring themselves again. And then for the rest of the day, we go into a sweat lodge. So it's a program that was created by elders and the women who are doing this work themselves. And in turn, we bring them into a mentorship program, and then we hire them on. And a lot of the ones that are on the fentanyl and the opioids, they come through the house. And one thing that, and I'm not saying anything is against this, but a lot of them choose not to do Suboxone and methadone because coming off of it is so hard on them when they have to come off of it. And I know that we've struggled with that a lot. That's been one of our challenges, running a cultural healing program and having, the different types of chemicals in their system. So I'm just sharing what they shared with me and what we went through. And a lot of them, too, don't steal. They don't do harm against anybody. They get caught up in sex trafficking because they've been drugged, and they're trapped in that. And this weekend, we went out to go look for a relative. We do MMIW work, too. And there were sisters out there on the fentanyl in Everett. Everett is really terribly bad. And just offering them love and support. They're trying to function and see who you are, giving them food, giving them a drink, calling them sister, telling them that we love them. That's been what we've been doing. That love is so important, like all the folks are saying today. And a lot of them do feel judged. They feel like they're stuck in this rabbit hole, and they want someone to save them. And they wish their family was out there looking for them. We hear this from them. So I just wanted to share that part of it and talk about more recovery houses that are needed, more transitional housings that are needed in the state, because it does work. I know at one point it was looked frowned upon, but it does work because they need those extra cultural healing tools to go back out on their own and wrap around healing services. So we've been really blessed to have the elders who have been part of our work to do the work at Spirit Journey House and keep it going. That's what I wanted to share today. And we have 3 beds open right now.
My name is Ryan Ortiz, and I'm from the Coeur d'Alene tribe. And I just want to touch on a couple of things. One, what my brother Anthony here said, when he said, I feel awkward up here next to the experts, and because I'm not an expert in the area. But I just want to encourage you guys to try to move away from that thought. Because everyone at the table, everyone in here is an expert. And I feel like I need to say that because I was in that position before. And I remember thinking, oh man, I can't say nothing because these are all doctors, these guys are counselors, and these are clinicians. And I remember thinking that I don't have a voice. And it just took one person to say, no, don't be like that. You're an expert. You have a voice. And I feel like when we look at recovery, we look at it as if we know what these guys are going through, what we know their history is. And we talked about COVID-19 earlier a couple different times. And during COVID-19, it was tragic, it was scary, it was all of those crazy emotions, right? But we got to see some amazing things happen. Like people came together, we were looking out for one another, doing fundraisers, opening up shelters. We came together as a community. Could you imagine if we did the same thing for people still suffering with substance use disorder? Could you imagine if we did all of those things for people who are hurting? And it's because we look at it different. we look at it as a crime. How many of you know somebody who's lost in their addiction still, who set out and said, you know what, I want to be one of those zombies? Who said, I want to be a thief. I want to be a bum. Not one person. I've been in recovery for 10 years. It'll be 11 years next month. And I never wanted that for myself. When I was growing up, that's what I wanted to be. I want to be a doctor. I ran around, I did all this, that, and the other. I'm like, oh, I'm young, I'm just going to party around. I never wanted to be an addict. I did 6 years in prison. And when I got out, I was so scared to do this, to speak up. I wasn't an expert. Nobody would listen. But we have to change that. And until we do, we're just going to be chasing our tail. We're going to keep chasing our tail until we empower the most important people at the table. In my opinion, is we need to be talking to the people who are hurt, the people who are suffering. The most powerful, the most scary, the most hard-driven words that I heard from an addict, my brother. And I said, why? You have kids. Why do you keep using? Why do you keep going back out there? He would get sober for 5 months, 6 months, 7 months, a year, and then he would turn back around and go use. Why? Everyone tells me, that's your brother. Why aren't you? You're out here getting everyone sober. Why aren't you helping your brother? I don't know the answer because the only thing I know is what he told me, because it doesn't hurt. And that to me is scary, because we don't look at people who are lost, who are being zombies, as people who are hurt. We turn our direction. Oh, he's going to ask me for $3. Oh, he's going to ask me for my change. I want a cigarette. We look at them as scary people rather than looking at them as people who need prayer, people who need love, people who need compassion, because we're okay. But when we have COVID-19 that's doing the same thing, it's killing everyone, we come together and we look out for one another. That's my first point I want to make. My second point is the access to recovery. And we talked about it a little bit here at our table this morning about people who want to get sober. How many people do we have to lose before we realize that that window of opportunity to get sober is this big? And the longer we wait, it just gets smaller and smaller. And we have that unique opportunity to help them before they help themselves. And how does somebody who's in active addiction help themselves? They want to feel good. They're hurting, they're asking for help, they want to feel good. And if we can't help them when they're confiding in us, where do they go? To what they know makes them feel good, to what they know is gonna cure that pain. And so we have to find those resources, and that's when all this great education and having the legislature and the right people at the table comes in handy, but we have to listen to them and say, what is it that you want? What is it that you need? And that's what we did in our community. We had meetings just like this, but we invited them. Come and tell us what you want. Come and tell us what you need. Come and tell us what you think is going to work. And we have a long ways to go, but we have so many people in recovery today. We could probably doggy pile up to the ceiling a couple of different times. We have a recovery community where people just band together. We do sobriety camps. We do all these activities together as a family, the recovery family, and they look out for one another. I remember when I first entered into recovery in 2013, it was me and my daughter alone. And it was lonely. I didn't know, I couldn't go nowhere because it was risky. I couldn't hang out with my friends because that's risky. And now there's just so many people who are blossoming into recovery, but we have to keep going. We have to keep pushing for those resources. Otherwise, we're just going to keep chasing our tail. And we have to look at what we're going to do to sustain people's recovery. We have this this process where we get people the help that they need, we get them sober, we get them into inpatient and then outpatient, and then what? We find them jobs, and then what? Recovery. For those of you who know, about the recovery journey, it lasts forever. There's no beginning and end. It's an ongoing battle, and I know people who have fell off the wagon at 20 years, 15 years, 30 years. You have to keep maintaining, and if we don't invest in the recovery support services after the outpatient, after people have gotten a job and gotten their kids back, and I know so many people who've done all those things and got their kids back, and they're like, now what? What do you do after that? We have to look at what we're going to do with those people, because those are how we're going to get people up here who are going to be giving you guys the same feedback that I'm giving you right now, and they're going to be able to say, here's how I did it. Here's how I got 5 years. Here's how I got 10 years. Here's how I got 20 years in recovery, so that we can continue to build and establish a healthy recovery community. Lim Lemch, thank you.
And then we have someone in the back here.
Good afternoon. My name's Evelyn Jefferson. I'm a Lummi Crisis Outreach Supervisor. Our team goes out and we do outreach for our tribe. Our morning report looks from our counselors to our psych team, and we get the reports of our community members that may end up in the ER, related to behavioral health issues, some kind of crisis, opioid. But my concern is the Addicts, Drugs, and Alcohol Center for Disease Control at the University of Washington gave a report out in April, and they analyzed from the crime unit for crimes from the State Patrol all of the fentanyl and everything that's mixed with it. And some of our paramedics in town are seeing that the fentanyl overdoses, that Narcan is not working. And they're using like 3 Narcans on a person, and it's not working because of the mixture of what's in it. And that's my fear, when we go out and we might have to use our Narcan and it doesn't work. In our homeless camp lately, there was a person that died of an overdose, and the fentanyl was 3 for $10. And it was just that easy. And it was somebody that we were tracking for cellulitis in their legs, and it just got so bad that they had to go to the hospital, get leg amputations above the knee. When they come out of the hospital, we didn't have anywhere for them to go. They ended up back in the homeless camp and overdosed 3 weeks later after she was out of the hospital. And Narcan didn't work on whatever it was that they're taking. And we're seeing a lot of this with the clients that we see with the cellulitis, with the wounds that are not healing. They're going to the doctor, and it's to the point where they're going to have amputations or, sent to Seattle for life-saving surgery. And this is more and more of what our days are looking like, here on the reservation. And I'm just wondering, is there anything else coming out that will assist Narcan because of the changes that the fentanyl are doing?
Yeah, thank you. That's a good question, and I'll invite any of my other physician colleagues. What you're describing is the effects of xylazine, which is a horse tranquilizer, and it's being seen more often in fentanyl within Washington State. It acts in a completely different way than opioids. It works sort of on the central brain to slow down respirations and cause sedation. So if someone who is known to be using fentanyl or other opioids gets Narcan, that doesn't undo the effects of the xylazine. So it is, if the recommendations now, if xylazine is in your community, and it sounds like it is, because one of the other things that can happen when people are smoking or injecting it is these horrible skin wounds. And it doesn't have to be where they're injecting, it can be in other parts of their body. And people in the other parts of the country, the East Coast, who've been dealing with this for a couple of years, talk about the horrible amputations and infections. So 2 things: if Narcan alone isn't working, then rescue breathing. which is what we did before we had Narcan everywhere. So not mouth to mouth, but there are face shields everywhere. I know a lot of first responders are carrying the ambu bags that you can use, or the face shields. So if Narcan, 2 doses of Narcan doesn't work 2 or 3 minutes apart, think about, is there a need to do mouth to mouth? Because Narcan will not work on xylazine. So that's one thing, and I think the other thing is really focusing on the xylazine is added to the fentanyl to give people an extra boost of that high, and oftentimes they don't know it, they wouldn't seek it out, but it's in there. And so really, how do we get people, when they have that very small window this gentleman mentioned, to the services they need so that they don't do that? And obviously, it pains me to hear that we're having people with cellulitis go back to encampments, because that's the best we can do. We've got to do better.
Hi, I'm Gary Franklin. I'm the medical director at LNI. I reported the first deaths in the country from prescription opioids in 1995, and in 2005. But I saw what happened in the state in 1999 when the drug companies and their surrogates had a misinformation campaign and really duped us all and duped all the doctors in the state into believing that opioids were not that addictive. They basically said opioids aren't as addictive as we used to think, and then they got the Department of the State Medical Board to change their rules to say that no doctor shall be sanctioned for any amount of opioid written. The doctor could be handing out bags of opioids, and the State Medical Board couldn't do anything about it because of these lobbying efforts that went on from the drug company surrogates. So we spent a lot of time trying to, through the healthcare delivery system, trying to reduce unnecessary opioid prescribing and reduce harmful opioid prescribing. A lot of that has gone down, but it hasn't gone away. There are still 17-year-olds who are getting their teeth extracted and getting 20 hydrocodone pills. They only need 1 pill, if any, because Tylenol and NSAIDs work just as well for that pain after an extraction. And then you have people getting surgeries, even minor surgeries. 6 to 8% of people who get surgery go on to chronic opioid use when they never had any opioids before the surgery. So the way that, the piece here that I think I could contribute to or help our conversation contribute to is to figure out how the health care that's being delivered to tribal folks, whether they're teenagers or older people or whatever, what is happening with their prescription opioids, and how is this all starting, nipping it in the bud. So I'm only talking about the one part of prevention that would stop this from happening and right from the very beginning of the first prescription. And looking at dental practices being delivered, looking at surgical practices being delivered are 2 places that we can look at.
And you know, a lot of medical providers are not trained in substance use, and they need to be trained. It's not a part of their education and training to talk about substance misuse and addiction. So this is a thing that needs to change, because some of our biggest drug pushers are our dentists and our doctors, because they don't understand, and they are being lobbied by the drug pharmaceuticals. So the other thing I want to add to you, what you were saying is, one of the things, I think there's a misnomer that Native Americans have some of the highest rates of substance misuse in the country. We also have one of the highest rates of recovery. So let's not forget that. We have one of the highest rates of recovery for a lot of reasons that we've been talking about today. So we have a comment over here, and then we have a comment over here.
Hello, good afternoon. My name is Willie Jones Jr. from Lummi Nation here. I just wanted to touch on the prevention side this morning on some of the things that we have been doing here in Lummi and how it's kind of fallen short. I coach a canoe club here in Lamine. I've done so since I was about 15 years old. My dad done it before me, and my grandparents and uncles did it before that. And so I focus on primarily youth. We have men's, women's, and youth also. And so, back early on when I was learning how to skipper and coach, I was all my friends that I was coaching, and remember how much fun it used to be and the activities that we did together. We used to go camping every weekend to different races on different reserves all over BC and all the way through Washington State here. And that still happens today. I coach a lot of kids, and doing so kind of figured out how many homeless kids we have, because a lot of the kids that I coach they don't have parents at home, or their parents are actively using, and they have nowhere to go after canoe practice, because I pick them up every day and I bring them home every day. And so I used to go around to the reserve and pick up all the kids that pulled canoe. Then I'd show up down at practice, would go and do our thing, then we'd get done and go home. And a couple of kids would always stay on my truck until I got home. 2 or 3 kids would always be there, and they'd say, "Oh, we just want to come over your house and play basketball for a while." But, in turn, they knew my wife was cooking, dinner. And so she'd always cook a little bit extra, and they'd eat, then they'd wander home. But that happened all the time, and it was pretty much the same kids, and you could tell what was happening, and we knew their parents were using during them times. But them were some of the best kids we had. They were the most dedicated, the hardest working, and they loved it because my mom is a really good cook. She used to come to our canoe races, and she cooks big breakfasts, big lunches, and big dinners. And she said, that you got to be healthy if you're going to pull a canoe. And so that was one of the things that the kids always looked forward to, was being able to eat. Because there was years later, after I coached for quite a while, I asked some of my kids, I said, "What was your favorite time pulling canoe? What do you remember the most?" And I thought they'd be saying, "Oh, we took championship this weekend," or "We won this race." And most all of them said the food that Grandma Josie cooked. That was our favorite thing about canoe pulling. And we have so many hungry kids out there that we model a lot of our programs after that. Nowadays, when our kids have youth programs going on in our tribe, they feed them there now. They feed them dinner before they go home. We have a youth academy that's going down here at the Lummi, and that's one of the things they do, is an after-school program where the kids go there, they do their activities, and they make sure they feed them dinner before they go home, because they learned the same thing as we did. I went down there and I listened to their program, and that was just one of the things that they came up with, is that they needed to feed the kids before they went home, because they'd go home to nothing to eat, and they wouldn't eat that next day. And then they found that kids that were not eating or not having someplace to go, they were surfing couch to couch, uncles, aunties' houses, that they were having low attendance. But when they ate them foods and got that stuff, that they were having better attendance once they got a program going for them. And so it really helps that cultural aspect of things, because that's what we do, is we feed our people. Whenever we do anything, that's the first thing that we want to do, is feed the people. And so, one of the other things that I wanted to talk about was keeping kids included and keeping these programs funded. When I was younger, we got a chance to go down to California to a canoe race, and we only had enough money to take 5 of the top pullers with us to that race. And then there was another kid that wanted to come so bad, and we had to tell him no. We only have enough money for five kids to go. And he asked again the day before we left. He said, "Can I go?" And he goes, "I'll just jump on." And we had to tell him no. And we left that weekend, and we got down there Saturday just before the race. We got a phone call from his parents and from the community here that he got in a car and started partying that night, and they got in a car accident, and he passed away because we had to leave him home because of funding. And so these things are really tough to hear when you hear that, we have no funding for that kid, or we have no funding for that. When we do, if we shuffle funding around. But one of the things that was going to lead up to is the funding we get from the state or the government. You know, there's so much restrictions on it, and it's so competitive to get funding through them grants and programs now that we lose 40% of that to reporting and documenting stuff. The employees that are handing that funding out have to do so much reporting, and it's so competitive with other entities that, you know, that money could be going towards the youth. You know, we've showed that we know how to spend the money. We're capable of managing our own funds and stuff, but still we have all these grants that take up all the extra time to do the reporting. It's just, if you ask anybody about grants, that's the biggest problem, is the reporting that it has to go with it. And so, you know, we got self-governance. We just went through COVID, and, you know, they dished that money out so fast, the money came in, and we were able to fund everything we needed to fund through COVID. We got things fixed. We showed that we could do it, but why aren't we doing that for this? Like we said, we lost more people to fentanyl than we did to COVID. We shut the whole freaking government down. We shut every school down, every business. Everybody had to stay home until we figured out how to tackle this problem. And we did it. You know, we lived through COVID. It took us a couple of years, but we did it. Why can't we do that with fentanyl, with this crisis we're in? We declared a state of emergency on fentanyl here in Lummi, and, you know, we started tackling these problems here at home, but that's the main thing we're running into, is the funding part of it, getting funding to fund everything that we want to do. We have all these programs set up in Lummi here that will help. We have Penny Carroll, and we have Evelyn here. We have the care office. We have our youth academy. And all these to be funded, and we're looking for funding to spread around to these people that want to help and know what to do. So we just need that funding to be cut loose. We know what to do with it. We know what to do with the funding. And we, you know, I've been a volunteer coach since I was 15 years old. We don't get paid to coach the kids, but another thing that happened was, like you said, the culture is really a big part of help and prevention, and that's true, because I worked with some of the baddest kids in Lummi that, you know, they were really behavioral problems and thought they were tough and stuff and trying to be gang members and stuff like that. But our judge at that time came down and asked if I would sign off on hours for kids if I would work with them. And so I did that for a few years, and so I'd get these couple of bad kids a year to take care of, and, you know, they'd start out being all tough and hardcore and stuff, but you start feeding them and start talking to them and start, you know, showing that compassion and stuff about, you know, this is your culture, and your uncle used to do this, your grandparents were sitting in that same seat you're sitting in, and they'd get all interested, and they'd be like, oh, really? You know, what was he like? You know, you'd say he was one of the best pullers I ever seen, and they'd get really interested and stuff. But that kid turned his life around, and nowadays he works up at the tribal office, and he's a really good kid, but he was going along that path to be one of the worst kids in Lummi. And that happened quite a bit throughout the years. I mentored quite a few kids that came through the court system, and they're doing really good now. And so that really works, that mentorship and that culture that works together. So, you know, that's kind of all I had to say today, but I just wanted to thank you all for coming together and putting this on. It's good to see you all here. Like Tony said, there was only 10 people here last year, and, you know, hopefully next year we'll break this wall down and fill the whole room with you know, all these breakout sessions. So thank you guys. Aishka.
My name's Janet Van Stiegel. I'm a Chehalis tribal member, and I work for the Chehalis tribe in the behavioral health department, sort of with SUD, but I focus on MAT and recovery. So someone was talking about the Narcan and that it doesn't work on fentanyl. And every time I hear that, it kind of makes me cringe inside, because I've worked for the last 4 years trying to break the stigma of Narcan. when I first started trying to hand out Narcan at like our annual meeting or something, most people would be like, no, not here. I'll come to your office and get some later. I don't want to take it right now. Because to them, if they were taking Narcan kits from me, that meant that somebody around them must be, using, and they didn't want anybody to know that. And so it's gotten exponentially better over the last 4 years. But then now I have people going, well, fentanyl's the problem, and I heard that it doesn't even work on fentanyl. It does. We have recently had 2 saves, which, by the way, we really need to start seeing Narcan saves as deaths in terms of threat and data. Because just because we had this miracle medicine that brought them back doesn't mean that the thing that brought them there and caused that is not causing that. And we're not taking that as seriously when we see them up walking around the next day. We have to change the way that we think about that as well. But anyway, we've had 2 recently. One took 7 hits of Narcan, and one took 10. So what I've started doing when I package Narcan, I was doing the Narcan kits, the little red package with the cross on it, with 2 hits of Narcan. And now I do fentanyl specific that have 4. And when I do the trainings with anybody that I give them to, I say you have to make sure that you're calling 911 at the very beginning of this. You have 4, and you wait your 2 minutes between them, and if there's no response, then you do the next one, and then you do the next one, and first responders should be there by then. And they can then take over whether they have the injectable or if they have more of the nasal delivery. But Narcan does work for fentanyl. It just takes a lot more. And then to the xylazine thing, the tranq, that becomes a whole other thing in terms of the stigma of Narcan, is because we hear it doesn't work for Narcan. So it's there, or Narcan doesn't work for tranq. So it's there, but, and by the way, we were just told by Millennium, who does our drug screens, that tranq has been identified in at least 1 specimen in every county in Washington state. So it's not as widespread as like Philadelphia and New York City in particular have been, like, it's like 90% of the street supply of opioids in those cities have tranq in them. So it's not at that point yet, but it's everywhere. It's at least a little bit everywhere. And then you have an overdose, the overdoses of the fentanyl. You do the Narcan, but then the respiratory is compromised, and then you've made a sober person having to deal with not being able to breathe, and that's a scary thing on top of everything else. So stigmas are popping up all the time, even with what can help, even with what brings people back. There's stigmas about having it, or having it on you or not having it on you, and when to use it and when not to use it. So whenever someone says that it doesn't work at all, it just like makes my heart hurt a little bit, because I don't want anyone to ever have the reason to say no to Narcan. And I just want to say that I have given hundreds of doses of Narcan away now on our small reservation. So it's picking up. People are listening.
Hi, my name is Heather. I'm here for a few different reasons. One of them is to talk about the kids. They're starting to use younger and younger. And funding for treatment for adolescents is so hard to find. We're so full. We have so many kids coming in. It's almost kind of overbearing how many kids we have getting in. And these are the ones that you guys are talking about. I love everything that everybody's saying, but it's starting younger and younger now. And treatment for kids younger and younger is harder to find. We talk about the kids, and the first thing I think of is the ACEs, the adverse childhood experiences. And we're talking about this is what brings these people to start using, but we're talking about this in adults. But it's not talked about as much in the kids, and it's just as prevalent in the kids as it is in the adults. The other thing I'm here to talk about is not only tribal nations. I mean, yes, tribes need help, absolutely. I'm a member of the Colville Confederated Tribes, and yes, tribes need help. But there's also urban Indian organizations, and that's what I do. I'm a treatment counselor at an urban Indian organization, and sometimes I think those people get forgotten because they don't live on the reservation, because they aren't with their tribe. They are sometimes forgotten. And that's tough because we were all removed from our lands at one time. People were displaced, people were moved, there was relocation programs, and that's how families ended up in these urban areas. And we need to not forget those people that are still in these urban areas and still need help, especially our young ones, because we're losing more and more of them now. So they don't even make it to adulthood. They don't even get to experience some of these life milestones that other people have experienced. So the thing I like to tell people is, because I work with teens, I work with adolescents, and I love it. I love my job, I love what I do, and yes, it is hard to have compassion for these guys sometimes because they are using, and it's hard to have empathy for them, and they are tough to work with, and not all counselors can work with adolescents. I totally agree with all of that, but we also need to create more counselors that can do that. We need to make it not as hard to get your SUDP license. There's so many barriers to getting it. I mean, and that's not helpful. We have, just in the treatment center I work at, I work in an intensive outpatient program for adolescents in Spokane, pretty decent sized urban area. We have over 40 kids in our program right now and 3 counselors. 3 counselors in intensive outpatient where these kids are supposed to be seen 5 days a week. It makes it tough. We need to start looking at these urban Indian organizations, these child servant agencies, also the prevention efforts that are being made to keep these kids out of the trouble they're in, to keep them out of where they're at, and get them going on this positive road, help them learn their culture, because that's what saves them. I mean, I grew up in an urban area, and there was only one Native organization in town at that time. One place I could go to see people like me and learn my culture, learn my traditions, because I didn't grow up that way. I was one of those that had all these ACEs scores. So hoping to save our kids in the urban areas is what I do. And it would be amazing if we could help all of them that need help, if we had the funding that we needed to see more kids, to help more kids, help them get back to their culture and get away from the drugs. So that's my compassion. That's what I'm here for, because I love my job, I love what I do, and I love these kids. trying to help them and help people see what we need is why I'm here. So thank you for listening to me.
I just want to do a time check because we have about 15 minutes and I have a stack of 4 people. So we have over here, here, over here, and over here. Excuse me, so we're going to get through it, but I just want to be cognizant of time and give you a break before the next session.
Are they next, or is it my turn? Okay, Sanisnat Kwakantanat. My name is Barbara. My English name is Barbara Juarez. I'm a member of the Lummi Nation. And I was just reflecting on some of the things that were talked about. And one of my notes was when the good doctor talked about the fact that treatment is needed for fentanyl addiction. It's really changing my thought process in terms of healthcare and substance abuse and the division of our departments within tribal communities and in the United States. So really, we had that mentality that everybody that was sick with addiction needed to go over here to get care. And then we created the opportunity for physicians to get a waiver so they can prescribe, and now recently the state changed that law, and it may be because the fact that the treatment that works for fentanyl is Suboxone, and so there is that discussion about going through no wrong door for getting treatment. You had talked about physicians not having all of the whole gamut of treatment mentality, but the prescription, the diagnosis and the prescription is the treatment that's being, so it's changing that thought process. The other thing is that when you create an MAT program and you have a limit on the number of people. So therefore, you only can allow 300 people to go through this door. And so that is also some of that thought process. And how do we change the system by creating a campaign by which people realize that treatment for fentanyl addiction, and so that really needs to be a campaign to everybody and not just the medical profession, to all of us, that there is treatment for those that are struggling with fentanyl. It doesn't have to be in that direction, that there are a lot of parts to that. The brain, we talked about the brain, and you also talked about the children. It made me think about the long-term effects of the kids, the long-term effects of the most vulnerable, which is our unborn. And the fact that you do talk about treatment, recovery, prevention, but we really need to include research. You mentioned it, Danica, but the Northwest Indian College Center for Health has actually done an amazing community-based participatory research that is evidence-based, that we know that individual, cultural, family, and community strengths are what's going to help keep us strong and get us out of a recovery. And my beautiful friend over here had to leave, but she's a perfect example of treatment, recovery, prevention, and now doing research in Indian country, turning that into actionable projects. So reducing limitations on grants, I think our councilman over here talked about, that's feeding. You know, some of those grants don't allow us to purchase food for some of our activity. So the administrative burden around reporting requirements for those grants, we really need to remove all those things. But research today is our friend, involving community, because we know that we know what we need, and then we can implement the activities. And the last thing I wanted to mention, when our councilman talked about aunties and his aunties, well, that's that healthy fear. And it's really important to have that healthy fear, and who you have that healthy fear to. It might be your teacher, it might be your auntie, it might be God, it might be this mother right here that says, if you don't take care of your kids, I will. And you need to get your shit together. So that healthy fear is really that anti-concept that we're out there spreading around. And it could be a teacher, and it could be a doctor, it could be a tribal leader. But that is really the parameters around what that means is healthy fear. So I'll stop there. Thank you.
Yeah, part of one of the projects I work on is we're creating an auntie and uncle society, and a curriculum around being a good relative to bring in that role back into our community.
Thank you. I'm Doreen Vargas, and my expertise is that I'm a great-grandmother of 5 last week. I have 2 examples. One is my grandson is going to be 25 this year, 24. He's been to treatment 4 times. He's type 1 diabetic. He is now in 6-month recovery, and he's doing well. He is a father of 2. His biggest challenge to us was that my grandson, he knows how to think and he knows how to talk, and he's very social and friendly and adorable. And he knew how to run circles around all counselors in a good way, not in a bad way. They loved him, and they did not know how to treat him or counsel him. One counselor actually did enough study to figure him out and got him to open up and his greatest fears. That was Shalina, an excellent adolescent counselor from Lomi. She's one that got him to open up and talk about what his issues were, you know, other than his number 1 trigger was that he was diabetic. He started at the age of 14. He's 24. He's still alive. Have you heard of Ricky's Law? We used Ricky's Law on him twice. The first time it failed because of the hospital here locally. They wanted to wait until he was mentally competent to ask him whether or not he wanted to go to recovery. If you're on fentanyl, you're never going to be mentally competent. So yes, the education in the medical system needs to happen. But he had to be the one to make that decision, and he did. The last treatment facility he was in at the end of this last year failed him in his medical needs because they didn't pay attention to his medical needs. He is now going blind. They ignored his need to have that care. The other young man is 22. He was lost in the system back when he was 12. He's 22. He's still suffering with the addiction. We tried to bring him in. His father tried to bring him in. He is a 3rd-generation addict. His grandparents, his parents, and him. He was born with the addiction. So at that, and as you see him now, he'll never be mentally competent because he's a constant user. His mother is serving time in prison. His father is fighting. He's in recovery and fighting for his life, his son's life. And we're praying and hoping for him. He tried to go into recovery once, but our care unit failed him and turned him away because they were too busy with other things. That broke my heart, broke his dad's heart. So we do need to take care of, as soon as anybody walks in the door, hold them, take care of them, nurture that recovery. Because during the pandemic and everything, a lot of our children that were seeking recovery were trying to find those four walls, that circle of chairs where they could find security and support that didn't cost anything, that didn't have to have operators that had to seek reimbursement to refund their program. It didn't cost anything except people's time. So we need those four walls to wrap those that are trying to find recovery and the support of others that don't get paid for helping them recovery. Because it's important to our communities. We know who those four walls are because I support them and I'll fight for them and I'll fight for those children. This young man will never know his culture because he was never taught anything. He's hungry for love and affection because he calls me grandma. And he asked me if I love him, and I say, yes, I love you. But I want you to love yourself too, and just find your recovery. I will, Grandma, is what he says to me. So we need to utilize all forms of recovery for all of our children, regardless of what that is they're looking for. Because when my grandchildren were teenagers, my doors were open to all teenagers, and I fed them meals. Sometimes I'd have more than 18 kids in my house feeding them in the neighborhood, and I did that with my own dime. Thank you.
Thank you for sharing. So we actually have a stack, and I don't think we're going to have time to get everyone. We have this lady here, and we'll go there, and then we'll see the time. Oh, yes. Oh, are we reconvening at 3? Oh, yes, we're reconvening at 3. So, JJ, you'll start at 3. Okay. Do we want to take a break? So, let's take a break. I do want to share a friendly reminder that we do have wellness care and wellness teams available in room 159. If you want to just go get some coffee and sit in some silence or get some body work or talk to someone, please do so. These are heavy conversations. We also need to take care of ourselves. So we will reconvene at 3. 3. Yes, we'll reconvene at 3. A grounding exercise. And I do this for every presentation and training I do. So those of you who've been in my presentations before, this is old hat. But I find them really helpful, especially when, we're going to be in the space for 3 hours together, kind of sitting down. We're having conversations about some really intense stuff. We're sharing stories, so we want to get grounded. And so I'm going to show, and you can use these skills for yourself in your work, in your life, in your world. You can also use these when you have a client who's dysregulated. I did this all the time in my practice. So I'm going to show you two. One of them is like 30 seconds. The other one is a little bit longer. It's some box breath. But we're going to bring some oxygen to our brain, and we're going to do a little bit of movement. So one of the things that we're starting to understand around trauma in particular and the regulation of trauma is this really amazing thing called the vagus nerve. And it's this massive nerve that really kind of regulates almost every part of our body and our system. And there's a very simple way that you can regulate this nerve. And so I'm going to show it to you first, and then we're going to collectively practice it. So I need to put my mic down, so I'm just going to show it to you. Excuse me. All right, so just kind of get comfortable. You can do this laying down on the ground. You can do this sitting. You can do it standing up. I think the way it's really supposed to be done is you're supposed to lay down on the ground, but we won't do that. I won't make you do that. But get comfortable in your seat, and we're going to start with a couple of deep breaths. Get loosey-goosey. Move your neck around. We're going to start by moving our neck just back and forth. Not hard, we don't want you to push it. Just move your neck, easy peasy, back and forth. And then we're going to go to the right and hold it for just a moment. We're going to go to the left. We're going to hold it. Take a deep breath, and you're going to take your hands, if you can, and put them like this, and then stretch them out. Yep, big yawn. Do it. And then up. And then you're going to cradle your head in your hands, like really cradle your head, like push it back. Your elbows can be wherever it's comfortable, but you want to kind of have them flayed out a little bit. Really push your head back. And what you're going to do, you're not going to move your head, but you're going to move your eyes to the right. And you're going to hold it. And sometimes you're going to have a response, like a yawn. Or a sigh. Just hold it. Taking some deep breaths. Just let your body regulate. You go back to the center, look forward, blink it out, blink it out. Take a deep breath in, and then move your eyes to the other side. And you might have the same response, you might not. There's no right or wrong way to do it. I tend to yawn, so just hold it. Let's do it one more time. Go to the other side. All right, go ahead and look forward and then release. I don't know what this magic is, but it does something to regulate your nervous system. The other thing that I do with folks that I'm in work with is box breathing, and box breathing is amazing. In this kind of culture, we don't really do deep breath. And when we're in a trauma response, literally your brain, like the blood from your brain is going to either your organs or your large muscle systems to fight or flight, right? So box breathing helps you regulate your parasympathetic nervous system, and it brings oxygen to your brain. But you want to do it in a very intentional and thoughtful way. So you want to box breath as in bringing in your breath for 4 counts, holding it for 4 counts, releasing for 4 counts, holding for 4 counts, and then you do that for a couple minutes. And you can do it throughout the day, and it'll help you bring oxygen in your brain, regulate your parasympathetic nervous system. And so we're going to go ahead and try that too. So with it, and you can do it at your own pace, like some people like to hold in their breath and breathe longer. 4 counts is pretty good, and I'll do it with you by counting first, and then I'll join you in your box breath. But so go ahead and, again, release your breath. And then we're going to inhale for 4 counts. Hold. Release for 4 counts. Hold. Inhale, 4 counts. Hold. Release. Hold. Now just do this for a moment at your own pace. So with that, you can do this throughout the day. I do it throughout the day, especially when I'm like back-to-back meetings. I'll just take a few minutes between meetings and do some box breath. When I'm with someone who's dysregulated, what I'll do is I'll say, hey, it seems like you're having a hard time, you're dysregulated. Do you want to do some box breath with me? And then if they say no, we do it together. Or if they say yes, we do it together. If they say no, I just do it, and they're going to mirror you, because that's part of human nature. So if they say no, I say, okay, well, I'm just going to take a moment, and I'm going to take some breaths, and then I start doing it, and then they're going to mirror your breath. Human beings, we're just so weird. It's so cool. But at any rate, I just wanted to kind of get us back into the space and grounded, and also offer a tool to all of us who do this work. This is really, really hard work that we're doing, not just today, but in our life. Like, this is hard. And we don't, as caregivers, take care of ourselves. We're terrible at it. I'm the worst. So I wanted to just offer you a tool and a skill that you could get grounded and utilize, and also use in your practice if you feel comfortable doing it. And so with that, like I was sharing before, this is supposed to be a whole new group of people, but we have people who are new and we have people who've been here before. So we're just going to kind of summarize what we talked about in the earlier session and reintroduce, and then we're going to open it up for discussion. And really, we want to open it up for discussion to talk about what solutions you're doing or you're seeing or you would like to see in your community. And so with that, we will just go back down the line and reintroduce ourselves. Do you have your little box of, I'll pass it around. Yeah. But Halito Achichiok Shlubo Ahili Fijik, I'm Donica. I'm a citizen of the Choctaw Nation of Oklahoma, and I am the Behavioral Health Programs Director at the Northwest Portland Area Indian Health Board, and I'm the auntie in the session, so I'm really just kind of helping us get started, start on time, end on time. I've not been the best auntie in starting on time, but it is what it is. All right, you're next.
Great. Good afternoon. My name is Sharisa Fatinos. I'm the Medicaid Director and the Behavioral Health Medical Director at the Healthcare Authority. I will keep my remarks much shorter than earlier this afternoon. But basically, I had 3 themes when I spoke last time, and that was treatment, connection, and community. Treatment is medication. Medication is treatment. That doesn't mean that it's the only treatment people who have an opiate use disorder or another addiction need. But in the world of fentanyl, it's the first thing that people need to be able to attend, to normalize their brain function, to normalize their bodily functions, and to be able to attend to whether it's trauma, cognitive behavioral, traditional therapy, or other reasons. I show that it's different in the world of fentanyl. This is my show and tell. We'll pass it around again. There is a rock, pretend it's a pea. If that pea were pure morphine and you had not used any opioids prior to taking this pea-sized dose of morphine, you would overdose and die. The sunflower seed is the amount of heroin that if you had never used opiates, it would take for someone whose body is not used to opioids to overdose and die. And a tiny little sesame seed in there is the amount of fentanyl that it would take. More potent, more rapid acting, shorter lived, which is why people are, that's all they focus on, having to use it multiple times a day. So I thought this was a good visual to help frame in one part why fentanyl is so different. What used to take years for people to become addicted is now taking months, or to develop an addiction. So it's a different ballgame. We need to think differently. We need to approach it differently. Connection, we talked last time about empathy. Empathy is hard sometimes for people who are challenged in their day-to-day life because they're seeking not to feel sick. Once you've sort of initially started using opioids, that high is no more. You're just trying not to go into forward withdrawal, which is filled with anxiety and doom. So empathy is the ability to sit with someone and not take on their pain, but to be able to appreciate their worldview from their seat. Empathy, connection equals hope. We need hope, all of us, to get through our days, especially people who are living with substance use disorders. And community, I'll just stop by saying, I was at a conference last week and there was a reverend from Minnesota who is doing some remarkable work with communities of color in Minneapolis who are struggling with all kinds of things. But basically, he shared this definition of community, and I think it reflects what I, in my experience living in Washington for 30 years and working, has been with tribal communities. And its community is the way people behave when they believe they belong together. And I think more than any other group I've worked with, tribes understand that. You bring your culture, your past, your elders, your traditions to bear. And in my experience, I think Danica mentioned this last session, even though American Indian and Alaska Natives suffer from higher rates of substance use disorder, they have higher rates of recovery. And in my experience as a clinician, that's because of community. That's because you embrace each other, because you have your traditions, because you don't leave anyone behind. And so I think that is why I want to end with community.
Yeah. Thank you, Sharisa. I really appreciate going after you yet again. I went after her the first session and I was like, yep, what she said. Not really, but that didn't land quite the way that I wanted it to. Truth be told, nobody left, all right. I will say this, there were a couple things that I wanted to touch on in the first session before we move on. But for those of you that I haven't had the chance to work with, my name's Carrie Waterland, and I am our Director of Division of Behavioral Health and Recovery at the Healthcare Authority, and our state's Behavioral Health Authority. So really great to be here, very honored to be here, and thank you to Lummi Nation for hosting this and inviting us, so thank you. This is what I think I wanted to really touch on today is as we look at solutions for the opioid crisis, the fentanyl crisis, what we know now, a loneliness and isolation crisis. What do solutions look like? And we've heard a couple times today that folks have identified the longer we wait, the harder it is, right? And I think a couple people, even in this first session, said the longer we wait, the shorter the window of opportunity becomes. So what barriers are we putting in place for this window of opportunity that we know is already short? And then you had what Sharisa was just saying, fentanyl, and the process is so much faster, right? So we're already dealing with a tiny window of opportunity to make some interventions when somebody says, I'm ready. And then you tack on fentanyl, and we know, and we've established this already today, and folks have said this, especially for fentanyl, whole new ballgame, sometimes that rock bottom is death. And if we're not there with Narcan to help to bring someone back, what does that mean? So I'm interested in hearing a lot of this minimal short window of opportunity, what barriers have been experienced that we can try to work away from and take away. And I'm just really excited about that particular piece of the conversation and leaning in, so that some folks from the earlier session, that was kind of some of the stuff that they brought up, and then we're going to look to you to help us find some solutions from those things. So I'm honored to be here. Chairman.
Thank you. My name is Tony Hilaire, Chairman of Lummi Nation, and again, on behalf of our people, thank you all for joining us today, for coming together to have this very important discussion to address the needs of our people as it relates to this drug epidemic that is impacting all of us. Earlier, we were talking about prevention, intervention, and rehabilitation, talked about treaty and trust responsibility, our shared history here between tribes and the state, that we did not go to war, that it was a peace treaty, and in exchange, we asked for specific rights. And it is not our understanding of treaty and trust responsibility for us to apply for grants, for competitive grant funding, and the ongoing, lobbying for changing laws in the state and federal government. That we just need the resources, we need the understanding of who we are, and the understanding of the system that's been put in place to fight against us throughout our history, and our need to overcome that together to be able to provide some real change for all of our people. We want this discussion to be solution-oriented. We talked about, it's kind of like testimony versus solution, and testimony is what got us here. The stories, the perspectives that we have, and the work that we've done over the years, the constant lobbying and the bringing of people together to share our story is what got us to this Fentanyl Summit today. And now we want to talk about solutions. We want to hear from tribal leaders, tribal members that are within the tribal government, maybe on the front lines of the work happening within your tribe. What can the state do better? Where can we improve? What is your perspective? Where are the gaps? What are the issues? What are the laws? What are the funding needs? What is something tangible that we can walk away with today, and that we can bring to the governor of Washington tomorrow? And that's our goal here today. We'll facilitate the discussion, but we really want to hear from you all, not just the story, not just the testimony, but the real solution that you're looking for out of this time together today and tomorrow. And we plan to meet later this evening as facilitators to compile, and consolidate everything that we've heard, and then draft up something that will be presented to Governor Inslee tomorrow. And so we talked about, just to kind of recap, earlier we talked about grants, competitive grants, and direct funding needed to tribes, and the restriction barriers that come with some of the grants that are out there. Grants are great, and yes, it is funding resources for our tribes, but the reporting back of those funds and the restrictions that are put in place kind of insults our sovereignty and treaty rights that our ancestors and the forefathers of the state signed into agreement. We talked about healing workshops and training and making sure that it's culturally led. We talked about women and children in recovery, to love and support them by way of transitional housing, and especially housing for our youth and adolescents. We talked about that sometimes when we're caught up in our government or the laws that are in place, that we look at our people as criminals, and that we have to be able to talk to them, that we have to be able to meet them where they are at in their life and have an understanding. The doctor here talked about empathy over opinion earlier, and that's kind of what came from that discussion. We talked about accessibility to treatment, recovery, sustainability, support services, and with that, there was comments about our waiting time just to get people into a treatment or into a bed for detoxing. say is like 12-hour wait to get them there. And I'm sure it's a lot longer than that. But how do we measure that data, for one, and then also bring it into a way that we're going to address it so that we can set the goal that, well, we only want it to be 6 hours for our people to wait for a bed. And this is how it's going to happen, and then to organize better for treatment services, for where the locations are at, where all the beds are available, like a constant, organizational list of resources that are current and available at any given moment. We talked about Narcan isn't working due to the mix of drugs, but that it does still save lives, and we don't want to discourage people from the use of it, and also about data around death overdoses, and that we need to incorporate that when we're talking about the use of Narcan. And we talked about how healthcare is being kind of derailed, or there's kind of a disservice happening for how doctors are providing care, whether it be dental, surgical procedures, or providing medication. We talked about opioids and the misuse there, and how it's kind of led to a lot of the disparities that we see today, and how do we change that around by law for our doctors, not just within our tribes that are providing services, but outside as well when there's patient-referred care. We talked about canoe racing. We talked about that as being a form of prevention. You look at the people that paddle canoe, and I don't know if there's ever been research done or any type of data shown, but we think about the children who grow up canoe pulling. I can't think of one that's living this life of addiction, and how do we measure that, and then also incorporate it into our way of healing, and to address the drug epidemic by prevention. As a part of that, feeding our children, feeding our people, being our culture, and the kids who are out there, whether it be foster care or couch surfing at an aunt's or grandparent's house, doesn't have a steady place to live, that they're hungry and they need to eat. We need to be able to find them and to take care of them, and have that easily accessible for them as another form of prevention, better treatment, access and resources for adolescents, not just for adults. We talk about historical trauma that leads to adults to live this life and their need for treatment, but what about for our children, the ones who are kind of growing up in that life? What are we providing for them, not just on reservation, but also the urban Indians as well, outside of the boundaries of our reservation. We talked about a campaign to change the systems internally with the state, as well as the perceptions regarding fentanyl. Research and data. We had a great example of our Center for Health at Northwest Indian College, who is already doing a lot of the work of research and data, and that we need more of that, and that needs to be consolidated and combined. And then healthcare education, as well as better organization for care. So that's kind of where we left off, and we had speakers lined up. We had like 4 kind of in the queue to speak, and we want to hand it back over to the audience, to tribal leaders, tribal members who are working within the government. And these are some of the questions we asked at the last session, is what are some of the most important issues we need to confront regarding this fentanyl crisis as it relates to treatment, recovery, and prevention? What are the barriers and gaps in what we have available? And then how does that translate into solutions for the state to consider, for the governor and the secretaries and directors, so that we can spark some change? And we'll hand it over to Danica if you want to facilitate the first question or comment.
Can you hear me?
Yes.
My name's Rebecca Crocker, the Executive Director for the Healing Lodge of the Seven Nations out of Spokane Valley, Washington. We're comprised and founded by 7 tribes, Oregon, Washington, and Idaho. And I'm sure you're all familiar with the Washington tribes, Colville, Spokane, and Kalispell. Idaho is Coeur d'Alene and Nez Perce, Oregon is Umatilla. Big tribes, very progressive, and have a really good handle on what their vision for the future. We have been in existence since 1988, and we know more about adolescent substance abuse than I think a lot of people in this area. We've lived it. We've seen the kids transform from just basic alcohol addiction. Then they moved into co-occurring disorder, a variety of mental health disease, the historical intergenerational trauma. And now on top of that, now we're dealing with fentanyl and severe chronic cases of opioid abuse. 100% of our kids right now have been using opiates and 85% fentanyl, both the boys and girls. The girls are just now catching up with the boys. Don't want to leave them out with that fentanyl stuff. It's really, I guess, enticing to take, and they enjoy it, and they see it as a way to get away from all of the trauma that they have felt. So they're really coming into the facility with a strong addiction in this area. According to our counselors, we have severe to high abuse in both opiates and fentanyl right at this time. One of the speakers had said, well, we can work ourselves out of this. We have been in substance abuse since 1988. I don't see us working out anything in the next 10 years or 20. We have to come up with good, solid solutions that are going to help us deal with this. And the chair was saying they want some ideas about needs. I don't think you have enough time for all of the needs that we have. But in dealing with inpatient treatment and kids that are 13 years to 17, the kids that come in and we do our initial assessment with them, the majority of them start using alcohol when they're 8 years of age. They're stealing it from their family, and then they're getting opiates, and then now it's freely and available to them to get fentanyl. They don't even know what they're taking. When you ask them what is an opiate, they don't have any idea. Do you know what fentanyl is? Have no clue. But it does make me feel good. So they're going to take it, and they do, until they get into our facility and they realize how much of an impact it has on them, not only mentally, but also physically, how the toll it takes on them, because their systems are not developing at the rate that they should. We had a young gentleman that I felt really sad about, because when we tested him in the education area, he was supposed to be in the 11th grade. He couldn't even read. So we have a bigger problem than just coming up with a small solution. We serve kids from all over the country at the benevolence of our 7 nation tribes. And they have opened the doors because they know the problems that we have with the addiction within the Native American Indian population. And so we serve our 7 nations as well as kids that are being referred to us from across the country, all the way back to New York. They come flying in because they can't get to treatment. They can't get in. And I mean, we're at a point right now, we have 28 kids on our waiting list. They're from all over. And when somebody says, well, we turn them down, we have 28 kids waiting to get in, and they've been waiting. It's about a 3-week wait for them to get into the facility. So when you ask what we need the parents to understand what's happening to their kids Education is going to be key amongst all of this. If they're drinking, they're doing drugs, their kids are going to be stealing it from them. And that's a fact. We've had 100% of our kids say the first place they get their drugs is from their parents. So we know that that's, a pretty solid on that, because it's consistently over the years, this has been one of the comments that have been made. So having a center, we have 45 beds. So you can think that there has to be 90, we have 90 to 120 days that we work with our kids, and then they're discharged. They're discharged home to an environment we know is very risky for these kids. And so we work with the tribes, the local tribes, behavior health units, to make that transition, that warm handoff. And we hope that, we follow up with the kids. We get a lot of good comments from some of them that are still in the recovery process, which is great, great news for us. There's some that are still hanging in there. We have had a lot of success because it's focused on culture, and culture is our base of who we are, and we bring them back. They've fallen off the being involved in culture for the time that they were on drugs and alcohol. And so then when our treatment program brings them back into a cultural environment where they're receiving their treatment, and part of their therapy is culture. And they're doing really well. They get into it. Surprisingly, some of the kids that I thought were going to be the most difficult and would not adjust well have done the best. So we get them into we try to work with their tribe to get them back into using their culture as a method for treatment. So the area that we have a need for when they ask for need is that we serve 15 boys and, 30 boys, 15 girls. So we need another girls inpatient treatment center. That is very critical. Those are the future mothers of our tribes, and we need them to be well before their brains become, just totally burnt out from the fentanyl. So we need a place where they can get in, they can get into treatment, they can get in there as quickly as possible instead of having to wait. So that's one thing we need. The other is a detox center. That needs to be regional, not just over here in Spokane, but one, in our different areas. One in Portland, one in Seattle, one in the north part of Washington, where we are here, one in Spokane. Because they need to get in right away when they need it. When they tell you that, hey, I'm ready to go into treatment, I'm really messed up, I can't deal with it, they're threatening to kill themselves, they need to get into detox, because they're all wiped out. And so we need to get them into detox as quickly as possible. You don't want to drive them all the way over to Spokane for a detox center. And neither do I want to drive the kids over to Seattle, for detox. They'll have a hard time, and they could go into arrest from the stress in your car. So you don't want that to happen. So it should be regional. That would be my recommendation. The other is we need more adult inpatient treatment centers for our families. I think that would help if we had more, because it'll, I think by having more available at the tribal level, that'll take that stigma out from going into inpatient treatment. They need it. The family needs to be well so that when the kids go home, they're coming to a well home. And by making this opportunity available, you have more healthy families within your tribes, and then that'll make it easier to convince those that are a little bit on undecided factor to go. And if they know they don't have to go to an inpatient treatment center on their reservation, they can go to another reservation where the other treatment centers are. And that'll help with that stigma. So whatever we can do, as far as what's our needs, whatever we can do for our families is going to pay off in multiples, because we're going to have the educated kids. We're going to have kids that want to go to college. We're going to have kids that want to be working for the tribes at some future date. And we're going to have leaders, more leaders coming up. We need more leaders to help us determine how we can live in a society that feels that natives should not have self-governance. They should not have reservations. They should not have the things that they have. We get them in Congress, and they start advocating for the rights that we should have as people. And we have a lot of rights that are not quite given to us that should be. So I just wanted to touch on those. Like I said, I have plenty, but I think that if we work together and we work and respect each other's tribes, and we get these treatment centers set up, that eventually, it's not going to be right away. I'm asking my staff to do a 5-year plan just basically on our and a feasibility study on the female inpatient treatment center. So we'll be coming to the state and asking you for help because we need to get that done right away. The girls are having a lot of difficulty dealing with the fentanyl, and more so than the boys, and I don't know why. We haven't figured that out. I was hoping we would be able to get some medical help and support from the Healthcare Authority or the Spokane Regional Health Department to help work with us and figure out what's really going on here, because it's changed. The kids are more difficult to deal with. Their behaviors are, they have like a short little wick of patience because they've been on these drugs and they're coming off a detox. Detox isn't just a 1-week thing. It takes them 30 days at a minimum to get through and start acting fairly decent. And we don't have a detox center. We have what we call a orientation unit, which we changed from orientation unit before we got fentanyl into integration, and we're keeping them housed in our orientation unit for a week so we can ascertain what level of addiction they're at during that period of time, and then what their needs are. We don't have MAT. And it's a issue that we're going to have to address because the state says we should have MAT. I think that's something that we need to talk about because giving them medication and they've got fentanyl. Fentanyl, what is fentanyl? Medication, right? So you give them medication to get them off of fentanyl, and I guess it's better for them. But whatever, is it designed for adolescents or from 13, 17 years of age? I don't know if that's the case. So we need some, I think, support from the Healthcare Authority to provide us with technical support so that we can learn more about what the effects of this type of medication is having on our kids, because mentally, we know that when they're in treatment after their 30 days, they struggle trying to read. And doing mathematics is a whole different story. So we're seeing this and that damage that is happening to them. So we need to figure out how do we deal with this and deal with it effectively. So our problem with the adolescents is probably different than the adults. But with the adolescents, the future of our tribes, we need to be a little bit more conscientious about what their needs are, because they're going to be growing up with this, and they're already damaged from it, because by the time they get to us, they're considered chronic, and they can't function very well out in society. Thank you very much.
Hello, hello. All right, there we go.
Thank you.
Shad St. Paul, Colville tribal member, currently working for the Spokane tribe, managing the behavioral health program. Listening to all of this, I think, I really appreciate the director's insight and wisdom for the youth. I would definitely say the same thing. I think a commitment to this crisis is absolutely necessary. There's probably some validity to declaring a public health emergency. The tribes are doing it. I think at a state level, you need to get ahead of this. We knew fentanyl was coming in 2017 through Millennium. I think I heard another person talk to about Millennium's insight into the use patterns that are coming from the East Coast heading this way. In 2017, fentanyl was halfway across the United States. Now it's everywhere. And I feel like xylazine is the same thing. So the intensity of this crisis is coming for us, and we need to do something about it now. We need to be more proactive rather than reactive. The barrier to the inpatient treatment door is real. If you show up under the influence, they turn you away. I used to work in an inpatient men's facility, and I've had to turn people away because they tested positive at the door. The capacity building that we're talking about for withdrawal management is an absolute need. I think another part to understand is that the west side of the state and the eastern side of the state are very different. Our populations are different, our values are different. The types of people that live on both sides of the states are different. The geographical boundary of the Cascades is something that needs to be considered. Many rural communities on the eastern side of the state, with maybe one major population center being Spokane. Everybody else has to travel to Spokane for resources and services in most cases. There are no outlying withdrawal management facilities. So again, capacity building, I think, and then you look at where I'm working on the Spokane reservation, we're roughly 50 miles from Spokane. So my biggest problem is someone showing up on Friday at 3 o'clock in the afternoon wanting to go to treatment, and we want to help them, and we will do everything in our power to try and get that person into a detox facility that day. But unfortunately, due to inability to manage capacity, everybody's full, and we prop them up the best we can over the weekend, and oftentimes we don't see them come back on Monday. So those are some of the big things. Capacity building, I think if you were able to declare a public health emergency at the state level, it frees up some of the funding that we're talking about. The limitations that we're seeing on the funding, inability to build facilities, inability for some of the federal funding to be utilized for building facilities is a real difficulty for many tribes. I know that there are more going up, but they're full. Everybody's full. There's no limitation. I think if you built 20 treatment centers in the next 5 years, that you'd be able to fill them all, because I think we're still seeing this roll out. It's still gaining momentum. Again, the disparity in withdrawal management facilities between the east and west side of the state are huge. There's a lot of withdrawal management facilities available on the western side of the state. I think we've got 5 in eastern Washington, and they are difficult to get into. Some of them are private pay, and there's only, I think, 1 or 2 that are Medicaid eligible. Another thing I was thinking about was like Ricky's Law. I mean, the involuntary commitment for people using SUD. It's barely even a Band-Aid with 72 hours. If we could extend that, similar to the mental health involuntary commits, where it can be up to 14 days, just to get their feet under them for a minute, get the actual withdrawal management occurring, putting somebody in a facility for 72 hours and then propping them up with some medication and then sending them out and hoping that they're going to do well is probably unlikely. I think those were my main talking points. Again, the logistics of trying to get somebody from the east side of Washington to the west side of Washington for treatment or withdrawal management, and then hoping that they make the transition from withdrawal management to the treatment facility is difficult. So just kind of thinking through some of those things and trying to understand, the differences between rural communities and some of these more urban areas.
JJ.
Oh, thank you, Danica. I just want to, actually, the reason I wanted to speak earlier, Danica, was a couple of ladies up front that spoke before break. I don't know who they were, Tony. They were Lummi tribal members. Anyway, I just wanted to make a comment. I heard, what one of them said. Well, both of them made very good points. And, I always look at things from an addict's perspective. That's my first focus. I'm an addict and an alcoholic. And my father was, and my grandparents were, and that's where I come from. So when I look at treatment options, the first thing that runs through my head is, would I do this? How would this work for me? When I was using. And, I went through our own wellness program. I was an intensive outpatient back in Swinomish in 2012. In 2012, we had our wellness facility. Across the street, we had our medical facility. And in our same building as our wellness program, we had our SUD counselors and our behavioral health folks. And as an addict, what we learned at Swinomish is most folks, they aren't willing to cross the street to their next appointment. I mean, that's the way it works. You go to see your counselor, and, that's good enough. I don't want to go walk across the street to my medical obligation. I don't want to have to go down the street from there to go see behavioral health folks. And nothing against behavioral health folks. I mean, a big push I have had in my community over the years, too, is behavioral health folks are great. But in Indian country, we're taught to not utilize them. We keep stuff internally, or we bring it out amongst family, toxic behavior. Mental health counselors, and Tony, actually, your mother works for Swinomish. She's we appreciate having her there. She's a great behavioral health counselor. We love her. And, but one thing we found with behavioral health folks is they have an office that most times folks don't want to visit, or they don't visit. So those behavioral health counselors, they sit there and wait for a native person to come through the doors that doesn't want to be there. And so it doesn't happen right away. I had that conversation with our team. How do you get out in the community and get people in the door? So I just want to say, what we found that works in Swinomish. I want to say some good things about what we have in Swinomish that we have found that works. And Digwal-Each Wellness Center works in Swinomish. We have all the services, I'll say again, under one roof. I share this, I'm excited about it only because I see it happening. We have almost 450 clients. We serve almost 5 counties. We have a transit system that goes and picks up these clients and brings them to the facility in the morning. They do and once again, it took me a while as an addict to wrap my head around it. For me, clean and sober means totally clean and sober and no assisted, medications. But what I came to realize is not everybody is capable of making that choice to get clean and sober right away. And we lose a lot of folks to this opioid crisis. So this SUD treatment facility, it saves lives. I've witnessed it. I've seen it. I've seen these folks that they get their lives back. They function. They get their families back together with this treatment facility. They get a home, a roof back over their heads. They get their families back. They get jobs. They're getting their driver's licenses. We have a dental facility now that helps with their smile. Their dentist. They get the behavioral health needs. We found that we have all these services under one roof. So people like myself, they don't have to cross the street anymore or get a ride 3 miles down the road to the next appointment, because that wasn't happening. So the success rate is very good at a place like Digwal-Each. And, we're excited about it. We can't say enough about it. We'd love to see other tribal communities. The billing that we are capable of doing it's under one roof. We're able to bill for the services under one roof. It makes sense. Not to minimize detox or inpatient treatment, because that works too for those percentage of folks that want to participate in that, that detox. You folks heard me talk about that earlier, my experience with it. So I just want to say it's a great thing. We've hired at Digual now. We've hired we've hired community advocates, and so these community advocates, they go out in the community. It's outreach program. For example, we're working with local hospitals now to have patients at local hospitals. No more, we call it stovepiping, right, or siloing, where you have just medical. In the old days in Swinomish, we had a medical clinic, behavioral health, and not communicating with each other. Now they communicate. They're under one roof and they all communicate with each other. So it's pretty exciting. We have an outreach program to local hospitals that are bringing patients in, a networking program. We have a pregnancy for pregnant mothers that are in treatment, that they're getting rides now down to Swedish Hospital and getting taken care of their prenatal needs. Our transit system is providing that for folks. So, I mean, there are solutions other than what I heard earlier about the siloing. It doesn't need to be that way. You know, we can get our services under one roof. We can get the care that our folks need under one roof. You know, and keep those transitions happening. You know, we have patients that can go to all 5 appointments: medical, dental, behavioral health, and counseling, SUD counseling, all in one visit, you know, in one day, where historically that was never possible. So that's exciting on the treatment side of things. And, you know, I do have to say that I was, the other thing I'll say is, if you have a chance to hire a person like Dr. Fontanos, or I'll say Dr. Parent, but he's ours. You can't have Dr. Parent. You know, in Indian country, bring him on board and you know, get things working, because it's exciting things going on in Swinomish. I will say the prevention side of things, that culture is a great prevention, we found. You know, Chairman Hilaire said it earlier, a lot of our canoe club kids, you know, they aren't using. They're excited about culture. They have no reason to use. I mean, our cultural families, our canoe families, are like extended families to our children. And, you know, if the home life isn't real great, they do have the culture family to rely on, which is great. It's working. Sports are another great avenue for kids. You know, organized sports. We see that works. And we had a great trip to Iceland. I'm excited to hear about that someday. Sometime here, Dr. Fontanos. That trip to Iceland was great. I hope these folks get to hear about it before we are done here at Lummi. But anyway, that's about all I got to say. Danica, thank you.
Thanks, JJ. I'll also add that the staff at Digual are trained in trauma-informed care, from the bus drivers, who are the first point of contact for clients at 4 o'clock in the morning. I'm not happy at 4 o'clock in the morning. All the way to the CEO of the organization. They understand trauma, they understand how it works, and they know how to navigate it. Important part of that project, I think, to highlight. If you go to the board website or even the Digual website, the statistics, the data for that organization are unprecedented. Unprecedented. So go check it out. They'll do tours and stuff. So, yeah. So we have over here, we have about 4 people in the stack. Ooh, you're next, but all right. We got right here, and then I'll come over to you. She's been waiting for a while.
Thank you. Good afternoon. I'm Aaron Soto. I work for the Muckleshoot Indian Tribe. I'm a substance abuse counselor, have been there for over 10 years. And I'm very honored to be here representing the Muckleshoot Indian Tribe as well. My question, well, I have a couple of questions, and one of those is probably for Dr. Fontanos, is the detox protocol, and if there is any possibility of extending the detox. Because most of the time, we see that as a 3 to 5 days, 7 days max, and if they're insured, and that is good to go, and they don't really pay attention to the patient. It is not a patient-centered approach, and that is very difficult to deal with when we know that opioid addiction, the worst thing that can happen to somebody is going through withdrawals. And with fentanyl, we see that happening 10 days, 15 days in. So that continues to be a very difficult process. That's one question. The next one is, this is a question and a request, and I continue to see, I have worked on medication-assisted treatment for over 10 years, and that has continued to be an area of debate, which is hard to understand why, and my request is to be open and be mindful that treating people with medication-assisted treatment, however the medication it is working, it has better results and is proven to help people who are deeply struggling with substance use disorder, particularly with fentanyl. One of the examples that I can give you is that at Muckleshoot we did an incentive program for people who were receiving Vivitrol injections, and we know that I have no affiliation with anybody. It's just that we had Suboxone, Vivitrol, open WeCare as well, which is a methadone clinic. However, the key part here to remember is that people get better with medication-assisted treatment. And at the beginning, when we started working with medication-assisted treatment, our own counselors were still debating what was better, if it was Suboxone or full abstinence. And reality is that we don't work with alcohol use disorders anymore. Like that is kind of like the secondary or the tertiary drug of use that is reported. Primarily, we see opioid use disorder. Secondary is methamphetamines. And the third is we're seeing alcohol, kind of like the occasional one that used to be the number one drug of choice at admission. And we stopped seeing that many years ago. We see the age of use for opioid use disorder in a younger age, and marijuana is not at 12 anymore. Like somebody mentioned, alcohol at 8, it's already kind of like a norm, and marijuana is not even consider an issue sometimes within the community. So that's still a gateway drug. However, the point of that I'm trying to make here is that when we started the Vivitrol injections and providing incentives, we incentivized people on getting the second and the third injection because we were seeing better results. And the results that the company did is the people that received the injection between 3 to 6 times, meaning 6 months, they had better results of recovery. So we were having a very difficult time to pass the second injection. So what we did is we started incentivizing people to get the Vivitrol injection. If they get the first injection, they didn't get anything. But if they get the second injection, they get a $40 gift card, and that was years ago. We probably need to bump it up, right? And but the third and after that, which is what we were looking for, we motivated or incentivized the program to use an $80 gift card. Our compliance rate went from 23% to 94% on people that were receiving the incentives. So people were staying longer on medication-assisted treatment, Vivitrol being one of those. We presented that in a conference with SAMHSA. It was just a tribal conference, but I was very proud of that achievement, right? And now this was heroin that we were trying to be against, because this is years ago. Fentanyl is no joke, and it's here. It's not going to go away. But my request or my call of action is to be open, be mindful, and understand that offering medication-assisted treatment, whatever that is better than nothing, because they will continue to use fentanyl, and that will kill the person. And the other thing that I wanted to mention is has anybody had any success with Sublocade? Nobody has mentioned Sublocade for substance use disorder. We're seeing that to be beneficial with more people. It hasn't been out that long, but people continue to use it and they like it and they stay on it, presenting no withdrawals when they are actually getting off of it. My recommendation for all my patients or the patients that we have is to try medication and stay with it. That at least give us the opportunity to create that contact and to have at least more days that we can see them in the office or in their places, in the community, but we have at least that connection with the patient so we can actually continue to go and have that relationship and build from there. So what I mentioned, 6 months later that we continue to see people on medication, it is a success for us. So thank you.
Thank you. Do anyone on the panel want to respond regarding any of those questions?
In terms of your question about withdrawal management, I think, I was just talking to Dr. Parent earlier. I think we're still working largely from the frame of how the treatment was set up initially for alcohol use disorder. It was 30 days of treatment. People got through withdrawal. If they had a history of DTs or seizures, they'd get medications for that. And then they were on their road to recovery. Fentanyl's changed that game completely. We have to think about withdrawal management differently. And I've heard from a number of substance use disorder professionals across the state, their frustration, we'll get people in and they leave 2 to 3 days later. Well, they're leaving because they're still in withdrawal. Fentanyl can take a long time to clear from the system. And one of the biggest symptoms of opiate addiction is craving. That doesn't go away in 2, 3, 5, 7, 10, 12, 20 days. And so to your point, we have to, I think, figure out, working with, Dr. Parent and other physicians out there, what do we need to do instead? Having people stop opioids is not going to be successful for them. We have to help figure out what's the safest and best way to transition them, probably honestly to another opioid for some period of time. Maybe it's 6 months, maybe it's the rest of their life. But nobody has that magic wand to figure out how to do that safely and quickly. And I think that's what all the docs out there are trying to figure out. Is it 7 days inpatient withdrawal? I don't think it has to be. Is it 2? We don't know. But Dr. Parent, I just asked him, I said, I need you and some other docs out there. We got to figure out what we need to go ask for. Because it's got to be some type of opiate therapy that doesn't put people into withdrawal, but slows their craving and withdrawal down so that they can enter into those trusting relationships and start their recovery. I don't think anyone knows the answer, but that's our charge to figure out how we move forward with that. But you're right, what we have now is inadequate.
Thank you. My name is Penny Hilaire. I'm the Lummi Nation Victims of Crime. And so my job is to rebuild and help women and children to rediscover their resiliency. So when we get them into a shelter, then we transition them into housing, sometimes a gated housing, and then into permanent housing. But a lot of times the mothers who have 2 or 3 children and toddler, we don't have access to daycare. And so I feel that our systems are setting them up to fail. Not just women victims, but all babies should have access. If we invest in our babies and having daycare for them, that I think we could really, we might have a generation that doesn't even have to be exposed to opiates. I always think about when prevention, the money that we support is strengthening our families. Canoe journey, canoe pulling, basketball, all that And so prevention to me is you're strengthening the families, and I've been saying it for 20 years. You know, I used to take kids to go swimming out in Canada. We would go to the water slides, and that beautiful to see how happy they are. They get to let their trauma be over here for a while. They get to be a kid. And it's not just a luxury, but you're just strengthening your families when they have access to prevention. And so I think that's really important that tribes need to invest. What does prevention, what does it mean when we're going to strengthen our families? That means giving our families opportunities, helping that mother so she could afford her rent while she's rebuilding her life so she has access to daycare. The other thing I wanted to talk about is I've worked with some community members, and they get really upset because our sauna's closed because they used it for their pain management when their bones were aching or when they were detoxing, and it became a community opportunity where they could support each other. And so more access for people that are choosing to be in treatment to identify what that pain management looks like, massage, sauna, whatever it is. I always believe the client is in the driver's seat. The other one is we talked about harm reduction. We have the harm reduction on the medical, and then I believe that we have to get intentional and have harm reduction as communities, like when we have where they pull canoe and we go down there, or we're doing a fun walk, is that we find needles, or we see people using down there. I believe we need to make the line in the sand and say no more, you're not allowed. We have to abandon or ban them from being at our community where our families are gathering. And that's just community-wise, because I'm telling the chairman. One of the other things, one of the mothers says, and she's been raising her grandchildren, one of them's graduating, but how do we communicate or give tools to mothers who are enabling their children? And she doesn't want her son to go steal from Walmart or Fred Meyer's, so go mop the floor, I'll give you 10, knowing he's gonna go get that fentanyl. So giving parents and grandparents tools to communicate with their addictive children. And this is a huge one, is that I get really upset about, is that we have all these homes, but the people that need the homes are either over income or they're lummy mom but have other tribal kids, so they separate from their partner, but they choose to enroll their children into a per capita tribe, but the mother's here in their shelter and she doesn't have access to housing, because your children have to be enrolled. So I'm sure this is not unique in Lummi. The mothers or the people that are trying to be well should have access to affordable housing. They shouldn't have to be broken or be an addict to get a affordable housing when they're trying to rebuild their lives. And then I think about, how do I educate, or how do we educate our kids that are in our schools? Well, back in the days, they used to have DARE, and I believe that every school was doing that curriculum. So how do we develop a program like DARE and Mothers Against Drunk Drivers? How come we don't have one that's Mothers Against Drug Dealers, that those fentanyl and heroines killed their babies? I think that it would be really beneficial. Canoe journey's huge in Indian country, and we have to get intentional and we have to talk about it so that kids are aware of it when they're at the canoe journey, or, you know, you never know. Because usually what's happening, it's our people are the little drug dealers. You have outsiders coming in, and they become drug dealers from someone the outside. And so we have to educate and continue to educate in all of our surroundings when we're gathering at a cultural event. One thing I've been talking to at our general council meetings is when we talk about harm reduction. So I was working with two mothers, and one of the mothers had 4 children, and the partner took the food stamp cards that the schools distributed. So these kids went without food for a month because the mother's partner took the cards and sold them to someone that works for us. And I believe we need policies in place where we're protecting the children's benefits. While they're out receiving benefits, our kids are. And so, you know, at Victims of Crime, we're able to feed them and house them and clothe them. But it's really hard to see that children that are supposed to be receiving these benefits and that aren't getting the benefits. Also, I was meeting with, because I have family members that are on methadone, can they use fentanyl while they're on methadone? Is methadone a pain relief, or is it a treatment for fentanyl?
So both. Methadone can be used as a pain medication. It's also used for, it's one of the medications for fentanyl use disorder, so people can be maintained on it. As people use opioids, their system becomes to tolerate them more. So you can always give someone too much opioids. It may be a lot. Methadone's a very effective opioid at binding the receptor. So in order to get a high off of fentanyl, they'd probably have to use quite a bit, depending on how much methadone they're on. But part of the whole reason people are on methadone is because it stops the cravings for fentanyl. That's part of its purpose. And it doesn't release all of the chemicals rapidly in the brain like fentanyl does. So it doesn't give people that enormous high. You might see people sleepy, but it doesn't give them that burst of the chemicals in the brain like fentanyl does. It's sort of a steady dose all through the day. So that's why it's a good choice for people who have opiate use disorder. And you might notice that people are on more methadone these days, and that's because it's stronger than Suboxone. And fentanyl is way, way, way stronger than either of those. So we're finding that some people need higher doses of the Suboxone and even higher doses of the methadone just to help their cravings and keep that up and down withdrawal and not withdrawal stable.
So I wanted to address one of the comments you made. I hear a lot of times that there's a conflict between harm reduction and community safety, specifically around needle exchange. And I will share that there's a program at White Earth in Minnesota. They've been dealing with this for a long time, and they've developed a program using peer recovery specialists to work with the community to address the dirty needles in the community. So I will share that with Chairman and with other people, that project and the way that that's working.
I also wanted to bring up some of the women use cannabis for their anxiety. So there are, I know people are against cannabis because they say it's a pathway to another drug, but some of the women are using cannabis so they can sleep and they have anxiety and so forth. So I know that some people are for or against it, but I see that it does work. They're not sticking a needle in their arms, and they're not smoking anything to hurt their lungs and so forth.
Yeah, it changes the risk, right? So, there, you're next.
One thing that I was just curious about real quick. So when we talk about solutions in regards to, I mean, all of this, but it was brought up methadone treatment. And are there any laws in the state or on the federal level that hinder our ability to give the needed dosage for those who are like really heavy in their fentanyl addiction? Is that an area of concern? Is there any, I mean, obviously there's no unlimited amount of how much you want to dose somebody, but have those levels been looked at, and is there anything that we need to be considering as tribes to change?
That's a great question. You know, as we've talked about, fentanyl is so much stronger. So if you look at the days of heroin and OxyContin, people who were on methadone were on an average dose, say, of 60, 70 milligrams of methadone. People are now finding with fentanyl that people often need 140, 150, 160 milligrams, and sometimes more. And that's just because it's more potent. So a stronger amount, a larger amount of medication is needed. One of the biggest barriers that I've heard from my colleagues who are working in opiate treatment programs is there is still a limit on the first daily dosing of methadone. You can only give 30 milligrams followed by another 10 milligrams, so a total of 40 milligrams for the first day. And again, all these rules came out when heroin was the opioid of choice in the community, and oxycodone, and they're way less potent. And so 40 milligrams of methadone was a pretty darn high dose, and that helped a lot of people initially get through their symptoms. Now that's not adequate. So there are a lot of discussions at the federal level about changing that initial dose, because people's tolerance on fentanyl is so much higher. There are also discussions at the federal level of relaxing the requirements. There is no ceiling right now on daily dose. It's just the speed. The most dangerous time for people starting methadone is the first 5 to 7 days. That risk is less with people using fentanyl because their tolerance is so high. But methadone is a drug that only folks who are familiar with it and its interactions with other drugs should prescribe. But there is a lot of discussion at the federal level to make it more available and to look at those starting doses.
So would that be advocacy or lobbying efforts? How do we change the law?
That's a congressional, a SAMHSA, DEA. Those conversations are happening. And probably the best way is one of the people I work with is Jessica Blow. She's our state opioid treatment authority. She has the designation and responsibility for interpreting all those rules, and she's engaged in those federal conversations. So be happy to connect her with anybody interested to talk about how to have that advocacy at the federal level.
Great, thank you. Sorry, Nate.
Okay, appreciate that, Chairman. Nate Tyler, Macaw Tribe. I guess I'd like to start off with, you know, I sit on SAMHSA and CDC, and one of the things we're trying to do is get them to look into marijuana. You know, as far as studies, I mean, I don't think it's a gateway drug. That's my opinion. So a couple things. You know, hopefully that happens at the National Summit. A couple thoughts. The lady, Miss Hilaire, stole quite a bit of my thunder. You know, sitting back and not just thinking about what we see, but living what we see. Towards not just treatment, but prevention. And I think it's important to note, you know, as far as prevention should start at the Head Start level. You know, we're starting to see this mental health issue. We've been seeing it for quite some time, and there's a reason for it. You know, anytime the debt ceiling comes up, it's always Head Start and SNAP and all these other programs that's threatening to be cut by Congress. And we're always fighting for them programs. So those are important programs, and that's where prevention should start. So I just want to add to what she was saying. Another thing, for Macaw, some of the barriers, and they've always been in place, always, access to treatment, Medicaid. You know, I don't know if it's true, but Medicaid's, from what I'm hearing, is stating that 14 days is what they're gonna pay. That's not, I think 60 to 90 days or longer for treatment is the only thing that's gonna work. We've been sending macaws to these, we only have so many choices to begin with, but we keep sending them over and over and over and over again. And at what point, I mean, that saying goes, you know, we're plucking them out at the bottom of the river. We got to go to the beginning and pull them out up, see why they're falling in the river. It was a number of years ago. It's been stated, we've been in this for 20 years or longer. My first time being elected was in 2000. In 2000, early 2000s, I kept telling everybody I work with, we got to do something different as far as treatment. I always thought the drug of choice kept changing, kept changing, kept changing, kept changing. Do we even know these treatment facilities are prepared to treat today's disease? I've never thought so. I have never thought so, especially heroin or fentanyl today. So back in 2017, I went and toured like 5 different treatment facilities way down south. The biggest problem that we see is a lot of these places don't accept Medicaid. So when they're not accepting Medicaid, but we have this humongous need, and everybody in the nation knows it, what do? It got to the point where we started paying for treatment way down south at some of these places that I toured just to see if they are any different than where we've been sending people. I don't know how many people in this room took care of a drug-addicted baby. I know that's not the right term. How many people ever took care of a baby that was going through opioid withdrawals? No one? Couple? We're not prepared to do that. That's another issue. 8 years ago, my grandson was born addicted. We got custody. Nothing prepared us for the withdrawals, the shakes, being up all night and sleeping all day. There's no test for that. There's no preparation for that. And that goes back to grants that the chairman talked about, access to monies. This last year, we've been saying, just give us the money. If it's intended for tribes, just give it to us. Don't get away from these grant programs. Get away from the state pass-through programs. A $10,000 grant's not worth going after. A lot of tribes don't even have grant writers. And if they have a grant writer, they can't compete with the tribes that have the best grant writers around because they're getting the grants. And then when you do get the grants, you got to be in compliance, you got to report, you got to do all this, all that. And when it's a one-man person, then you lose focus of the program. So get away from the grants. We know what we need. We're not going to mismanage it. And especially if the state's getting money, and that money's intended for tribes. I think that's important to know. Just get us the money, let us build our programs, let us put programs in place towards prevention. Not enough people here talk about programs for families that she was talking about earlier, putting programs in place towards enabling. We see a lot of enabling towards, like at Macaw, we know when there's a life flight. When that life flight comes in and it's for a mom that's pregnant, we know where that baby's going. That's at Macaw. And we see enough babies that get sent to, whether it's NICU or whatever the case is. So prevention, I think if we put more money towards prevention, we're going to spend a lot less money towards prevention than saving lives towards treatment. So Medicaid, the barriers on Medicaid, access to treatment, and long-term treatment. I always thought, I mean, a lot of these guys think they don't need the help. They don't need detox. They don't need treatment. They don't need the 12 steps. Some of them don't need the 12 steps. But long-term treatment, I'm a firm believer that if you go to treatment and you're addicted to fentanyl, then you should be there long-term, because what we're seeing is a number of our people are just totally losing it in their brain. And once that happens, it's beyond repair. It doesn't matter what we do. We commit them against their will, and they're probably not going to live much longer. I mean, their brain is, and we've seen that firsthand. And we're still seeing that. And that's another problem, is how long it takes to get these people help, to get them diagnosed, to get them committed against their own will. That's a big problem. When they need help, when their parents are terrified, when doctors are terrified that they're going to hurt somebody, but yet they need somebody from the outside to come in and actually diagnose them that they need to be committed. To me, that's a big problem. That's a red flag. 30 days is 30 days too long. So, and waiting for open beds in treatment. When a person wants treatment, we got to do everything we can to get them to treatment as soon as possible, because they're not going to get, we're not forcing them to go to treatment. When we force them to go to treatment, it's not going to work from what we've seen, whether it's judicial or whatever the case is. If they're forced against their own will, it's probably not going to work. But when they cry for help, that's when we got to bend over backwards to get them the treatment they need. So, but those are the few things I wanted to bring up.
Thank you. I just want to do a time check. We have about 20 minutes, and we have 3 people on stack. So just let you know. Thank you.
Hello? Okay. Hi, I'll be fast in mine. I'm Catherine Smith. I'm an addiction medicine physician and a family medicine physician, and I work for the Washington State Department of Corrections. And most of my points or things that I had written down here were kind of addressing funding issues. I heard a lot of people talk about programs that were really great and things like that, and we haven't addressed a lot of how can we fund these types of programs, or how can we expand services where they need to be expanded. So I was going to ask you guys, the panelists, about a couple things to see what we have going in Washington. One of them, recently I'd heard some expansion on 1115 waivers. I think I'm saying this right. Can you shed some light on what we currently have in Washington in terms of that?
We have an 1115 waiver right now for substance use disorder and mental health, and those, the primary pieces of those waivers allow for people to be placed in facilities that have more than 16 beds. There's a federal law that is called an IMD exclusion. That means that Medicaid won't pay for people in facilities that are over 16 beds. It's arcane, it's nonsensical, it's just what it is. So we have a waiver to be allowed to put people in those facilities for a certain amount of time. That is pretty much the scope of our waivers right now. We are asking to use Medicaid dollars to pay for contingency management in our current waiver. We'll hopefully know in June.
Mm-hmm. And we do have the potential in reach, but it's sitting right now with CMS for review, right? So we don't know. But there is also the conversation of the potential in-reach for 30 days into institutions. So Department of Corrections could potentially be, state hospitals or something like that. And so right now the federal government has a prohibition without a waiver where Medicaid can't be used inside of correctional facilities or other institutions that aren't certified by the Centers for Medicaid and Medicare Services. So in a situation like our state hospitals that do not have, Western State Hospital does not have a CMS certification, so we're not able to use Medicaid funding for that. Same thing, there's the prohibition for the Department of Corrections institutions, and we're seeing what we can do for that in-reach to get folks hopefully able to be enrolled in Medicaid services so that there can be a linkage with care coordination and connecting somebody with their managed care organization if that's what they choose, right? If you choose to go through the managed care organization route, so that that can happen 30 days, hopefully even more, but we don't know, before somebody is released. Yeah, so could be a big, hopefully could be a big improvement on folks getting enrolled into Medicaid services before leaving an institution.
Cool, thank you. The other question was about, we talked a lot, different people mentioned about the need for more detox beds or beds in detox center type things. I also work in a community hospital, and I'm under the impression that we can get Medicaid reimbursement for things like alcohol withdrawal or benzodiazepine withdrawal that are more medically complex, but we've never been able to get people into the hospital setting for pure like fentanyl or opioid withdrawal. Is that something that Medicaid might be covering or something like that?
Yes, we're considering that, trying to figure out how to do it.
Okay, cool. And then my last question was about expansion of potentially like early intervention programs. Some people mentioned support for folks that are family members of folks in active addiction. So how can we support them financially while they're providing that support to people in addiction? And I was wondering about early intervention expansion, so like helping people with childcare so moms can go to appointments, or helping with parenting classes for folks that are just early in recovery and things like that. What kind of things do we have available for that?
So I'm going to give a kind of, I think, a little bit of a government answer, which is states get block grants that are devoted for substance use disorder, and I know it's not SUD block grant any longer, but I'm going to for shorthand say that, and mental health block grants. And there is an opportunity and a set aside for primary prevention services out of the substance use block grant. There is not in the mental health block grant. That is actually not an allowable use of mental health block grant funding. And so I think if for some folks that were in the earlier session when I talked about kind of how can we move away from the diagnosis and get a little bit earlier on to some interventions, these are questions and things that we are really talking with the federal government about right now. So I should probably be using this, which is, how can we expand, and not just expand the way that we can use block grants, but it's not good enough to say, please use 20% of your block grant, but not add more money onto that. So we don't want to get into a situation where we have to make those choices between treatment and prevention and recovery support services. We'd love to be able to have the block grant opened up to be allowable for really anything on the continuum of care, and we're just not there yet.
Thank you, guys.
Yeah.
Thank you.
I'm going to try and be quick. Steve Kutz, Callous Tribal member, currently working for the Suquamish tribe. So I think I want to talk about a few quick things. We've heard about all of the different facilities that we need: secure detox, secure inpatient, regular inpatient, regular detox, regular inpatient. And also, we need to ensure that all of these are co-occurring, because it's not unusual for one of our kids or one of our adults to get into one of these facilities, and oh, by the way, they can't deal with their mental health stuff, and they blow them out. And so, and also, this state severely lacks youth inpatient mental health treatment. We have to send kids out of state. Inside of the state, they can't deal with them, so they don't cooperate with their treatment, so they blow them out and discharge them. We have to send them out of the state to get them stabilized. So we have some opportunities. We need to take together as tribal leaders, take a look at the landscape and see where we need the different type of facilities. Because what I will tell you, the non-tribal treatment centers out there and detox facilities, by and large, are not working for us because we can't get into them when we need to get into them. And oh, by the way, we have the wrong type of Medicaid, or we don't have, we're on open coupons, they don't take those. Listen, it's a mess out there. So we need to look at having a tribal system across the state. Take a landscape look and see what we need. We all can't have 29 full-blown everything everywhere in our communities, but we need to take a look at what the landscape is. And we have some opioid settlement treatment dollars coming up. If we all take those and we hire a couple people with those dollars, and we can already get Medicaid reimbursement for our staff anyway, we need to look together about how maybe we pool some of these dollars into facilities in the right place. And if we do it right, and we do it through Indian Health Service, and we get them on our annual funding agreements, we get 105L leasing and all the other things that help us cover the costs for those. And so, but we need to have places to ITA people. When you have somebody and you send them to our local emergency rooms, which is the typical way that we sometimes get them into our systems for an ITA, it's not working. It's not working. You'll take them into an ER, and you know what their answer is sometimes? They'll give them a dose of Ativan because they're in withdrawals and send them out the door. That's not going to work. So when we have somebody, if we don't have facilities for our use, we're just spinning our wheels constantly. The other thing that we need to do is we need to have the Office of the Insurance Commissioner involved in this conversation, because the Office of the Insurance Commissioner deals with the private side of the insurance side of things. So we have the Medicaid and the private insurance side of things, two different things. We need to have the conversations together. But we need to look at what the landscape needs, and we realize there's an east side and west side, but I will tell you, right now in this fentanyl time, when you have somebody in withdrawals, you can't take them halfway across the state. You can't even take them from one end of Puget Sound to the other sometimes with traffic and be able to deal. So we need to figure out what works for us together. So, and try and work together on all this. So we ought to sit down together as tribal leaders and try and figure out what does this landscape look like. Bring the experts in on what we need, and hopefully, if we get ahead of the game, we may not need all these facilities, but I don't ever see that. Don't seem like I see that happening. So thanks.
Hi, I'm Greg Thompson. I'm not a tribal member, nor do I work for one of the tribes, but I work here in Whatcom County as a health officer and also in Skagit Valley as a pediatrician, and a lot of my work overlaps the work that is being done here. And I'd like to speak to a few of the things that have been brought up before the break and after the break in regards to youth and children. So in Skagit Valley Hospital, I do work a lot with the babies who are born to mothers who were either in treatment or using substances during their pregnancy, opioid-exposed babies in large part. And I do really want to acknowledge the fantastic work done by Digwalich for care of a lot of these women that we take care of. Danica mentioned that people describe heroin use as a warm hug, that feeling of a warm hug. And I think in no age group is it more important to have that warm hug and have that contact than in babies. We know that babies who lack touch actually don't thrive. They can lose weight. They can suffer greatly from that. And one of the treatments that we use in the opioid-exposed babies is physical contact. We have a treatment we call Eat, Sleep, Console, or ESC. And our first approach in all of these babies, before we turn towards giving them medication to manage their withdrawal, is make sure that they are being held, they're being consoled, they're receiving that love and that warmth. And the first thing I want to offer with that is one of the strengths that people have mentioned in terms of the tribal communities and ability to achieve recovery is the families that offer support. So one thing I would throw out there is anyone who is interested in helping in whatever hospital serves your communities. Many hospitals have volunteer cuddlers that work in the nurseries, and they actually hold these babies. And we find that that can help babies survive or thrive through this experience of withdrawal and help reduce their need for being treated with opioids to manage their own withdrawal. Looking through my notes here. Next, people had asked about the outcomes in babies who are exposed to opioids, and I will say that it's very difficult to answer that question. We know that babies who are exposed in utero to alcohol suffer a lot of problems with that. We know babies exposed to tobacco suffer a lot of problems with that. Babies exposed to opioids, we honestly don't have very good data, and it's very difficult to know because there are often so many other adverse childhood experiences experienced by these babies who are opioid exposed, whether that's going through multiple foster homes or lacking food security, all the other challenges that often go along with parental addiction. So we don't have great answers there, but we do know that having those extended family supports can be incredibly protective. And then the question about teen drug use and girls and boys and how that's changing with fentanyl. You know, in the 20 years I've been doing pediatrics, the teaching has always been that young girls attempt suicide more often than boys, but boys die by suicide more often than girls. And the reason for that is that girls often use less lethal or less violent means to attempt suicide, often taking pills and those sorts of things where there's an opportunity for intervention. Now that fentanyl is here, when you take pills, there is no opportunity for intervention in a lot of these cases. A lot of these kids die. And nationwide, about 2/3 of the youth who die from opioid overdose deaths, about 2/3 of them have no known history of prior drug use. So it's often that first exposure to an opioid that is the fatal one in these young kids. So the message there for me is, you know, as parents, making sure that those drugs are locked up, making sure if there are medications that were prescribed for a surgery, that those are either out of the house or they're locked up where the kids can't access them. And the other thing that we see is deaths in very young children. Just a few miles from here in the last few months, we had a 5-year-old die where there was fentanyl in the house, and the baby took that fentanyl and passed away. I say baby loosely, a 5-year-old. So in terms of what needs or what action from this, you know, number one, around these babies who are born opioid exposed, any major life change is an opportunity for intervention. And a lot of the moms that we see that are still using when they have their babies, they have a transformative moment. They want to go into treatment. A lot of them want to go into inpatient treatment, but some say I'm only going to do inpatient if I can bring my baby with me. And there are very few beds for inpatient treatment in state with mothers and babies together. So that's a definite need that I would recommend lobbying for. Let me see. The cuddlers we talked about, youth mental health beds across the state. I would just reinforce that. That is a massive shortage. And I've got some other notes here which I can't read, so I'll spare you. Thanks.
All right. We are right almost at time. We have time for one more because I know you all are excited to go to Culture Night. And I don't want to keep you from enjoying the culture because we talked for just about 5 hours this afternoon about how culture is prevention. So we're going to go enjoy that this evening. So go ahead.
Renee Ramirez, program sponsor of the Lummi Healing Spirit Clinic, OTP. I just want to say I appreciate everything everybody opened up about, because coming together really gets juices flowing. And I have a lot of problems, but I'll give solutions that you guys kind of made my brain think about. So treatment, SWIMS facilities or secure withdrawal management. If we could treat them like hospitals, where, you know, cardiologists, brain surgeons, they're cracking chests and heads open all the time, and hospitals is big business, and they stay in business. Peace Health bought from Alaska to Oregon, I'm pretty sure, a bunch of hospitals. When we do treatment for these kids, the youth or the adults, we're getting into their hearts and their brains and healing all that damage that's been done. So that's one for treatment and SWIMS. Recovery cafes, there's no incentive to open recovery cafes, yet they're a huge place for connection, a huge place for healing. And so again, the system is broken. The ounce, I hate idioms in English because I get them wrong, but I think it's an ounce of prevention is worth a pound of cure. And so if we just remembered that, maybe money wouldn't be such an issue. And in regards to, actually that goes into the Iceland model. So creating a safe environment is really what's the core idea behind the Icelandic model. And so we have a culture room in our treatment program, and we know that works. Kanam earlier talked about that, how much it helped them. So that's in our treatment, not in our treatment recovery cafes. In the schools, the children need a safe place to be because we know they're not safe. That's what we deal with. We deal with children that don't have a safe place to be, so they get a hug from fentanyl now, unfortunately. And then in regards to prevention, I think for us I want to say thanks to Lucy because she's been a great help with our Indian Nation agreements. And yeah, she does need a round of applause because she's helped me a lot and taught us so much. For culture activities, it's easy. For secular activities like sports and basketball, football, it's harder. So we've had to create drug-free events to bring the kids together for sporting events. And other tribes have done these because we've sent our kids to your tribes. And I think that's one of the struggles with prevention. If it's culturally based, it's great. We can do the canoe clubs, we can do the healing of the canoe. But then the flip side is a little bit harder. Thank you.
Thank you, everyone, and thank you to our panelists for sharing and being here to listen and take note of all of these solutions that we came up with today. And yes, it's going to be a long haul, but we are going to do it. We are going to change the way we do business in this state. So thank you for your time and listening, and thank you all. We hope to see you at Culture Night. Chairman, do you have anything to add about that?
Yeah, thank you. Thank you all for taking the time. Thank you for your good leadership and especially the love that you have for your people and your community, and for all those that are from the state agencies as well. Thank you for being here as another step towards understanding one another. We appreciate this time together. And a reminder, Culture Night at 6:30 p.m., and we will have vans available for anybody that wants to take a shuttle over at 6 p.m. in the front of the Silver Reef Casino, the main entrance. 6 p.m. you can get a ride. If not, then the address to the school, which is right next to the community building where Culture Night is 2334 Lummi View Drive. 2334 Lummi View Drive, and it's in your pamphlet as well. We're looking forward to seeing you all there. We talked about culture being a form of treatment, being a form of healing, and we're looking forward to showing you what that is to Lummi Nation tonight. Again, thank you all for taking the time, and we appreciate each and every one of you. Haish Kasiyam.